Hell yeah. All right, let's go. So, cardiology is my jam. Before we get on cardiology, let's talk a little bit about the test. How the test works. If you're struggling, is everybody in here for sure?
So.
Okay. If you're struggling on the exams, or even if you're not, take that exam, look at the results. Figure out, I know it doesn't tell you what question, but figure out what areas you're lacking in. Study those areas. I sent out something yesterday. That is a Limmer product, Limmer Medic Prep, I think. It's a really good product. We've had good luck. You're going to need a product at some point. Okay? At some point in this class, you're going to want to get an app to prep for National Registry. I would recommend spending the $40, like $39 from Limmer. I think it looks like it's good for like a lifetime thing. Like not, it's either annual or lifetime. But at this point in your class, annual would be fine. We're going to do a new year. You'd be fine. Okay. So $40, it's not like monthly, as far as I understand. It looks like it's for a year at least, or not like that. The point of that app is so that you're in the line at the bank, you're at shift, you're between things, you don't have time for a platinum exam. And I know platinum exams don't give you real-time feedback, so you really don't want to take that as a learning thing. The app tells you immediate feedback. It is a learning thing. The platinum tests we're going to make you do are an assessment. Where are you at versus where you need to be? So before a big test, I'll probably take a platinum assessment, not the 30-minute ones. Those are too short. And I know we don't like long tests, but the 30-minute test is too small of a sample size. You get like 30 questions. If you pulled some bad questions out of that massive 2,000 some odd question bank, you don't know. You don't actually know how you're doing. So you got to take a real platinum adaptive test on the subject matter. So like, let's say airway. All right, airway, I'm going to take a focused exam on airway. It sucks. It's going to take time. You're going to have to actually sit down. You can't be on shift. I mean, you can, but you got to be able to focus. Okay. Then you get done and you're like, oh, I got a 72%. Okay. Or I got a 60%. And we're looking at the, not raw score. What's the other word?
Cut score.
Okay. So that's helpful, but the app is how you actually get better question to question. That is a study tool that gives you immediate feedback. Hey, you chose that this was unstable angina. It was really this because feedback learning, okay, that's possible, or that's possible. I told some students, I should have came in here and said that earlier, always start most basic. Only time you go to a big solution is when it's a really big immediate problem. Okay, anaphylaxis, big problem, big solution. We're either going to intubate or cry, depending on what the options are. Okay. Typical, unresponsive gurgling. What do we do? Open the airway and suction. Sometimes they say airway, open the airway or suction, and they're gurgling. So both airway. What do I do? Open the airway or is it suction? Well, I'd say unless it says the airways collapse, we're going to suction because we know suction's a problem if they're going, right? So a lot of it's inferring. You're like, there's clearly multiple problems here. Which one's the biggest problem? Treat the biggest problem, or always airway, breathing, circulation in that order. Okay, exsanguination, airway, breathing, circulation. Okay, does that make sense? When you apply that methodology, what they're trying to do, and you get a lot of the same style questions, they're trying to get you to jump to big solutions that don't need big solutions. Remember, it's BLS before ALS. They're trying to get you to intubate when you don't need to. They're trying to get you to add big oxygen when they don't need big oxygen. Remember EMT school, everybody got big oxygen? Not anymore. You're in med school. We think you have a brain. Okay. So, what is a ventilation mask? A bunch of people asking that. I think they're talking about a pocket mask where we're blowing in it. Would we pick a pocket mask over a BVM? No, never, probably. So, there's some, I get it, you don't have to like all the questions, but they're trying to get you to think outside the box. The good thing about the Limmer stuff, Limmer wrote the book. Literally. He wrote the first set of national registry tests. He had to stop writing them himself because he owns a private company now that literally writes the book on how to take the test. So this guy knows how these questions are. His videos on YouTube are stellar. We talked about an example, right? I don't want to spend a ton of time on this, but you gotta, it tells you something like you got a 90-year-old guy walking down the street. He starts having chest pain on his way to the post office. Okay? He's diaphoretic. He has dyspnea. And he pops a nitro prior to your arrival, unrelieved, continuing at chest pain. It's gonna give you some vital signs, throws out a bunch of numbers. Here's what I need you to do when you take that, and I just made that all up, right? You take that question. Do we care that he's 90? No, we care he's old. So take out numbers. Numbers confuse us. Geriatric, old dude. Walking, exertion. Signs and symptoms? Yeah, they match a heart attack, okay. Right? Give me a shortness of breath, chest pain. Fine. He already has nitro. It tells us nothing about history, but it tells us we have nitro on board. What does that mean? He has a history, folks. We don't walk around with nitro in our pocket. Do you? Hopefully. No. Okay. So he has a history. And then it's unrelieved. So here's your test answer questions. And remember, we'll get to about this in a second, but here's your possible answers. 1, unstable angina. 2, angina. 3, STEMI. 4, pericarditis. Which one can we rule out? There's normally 1, sometimes 2 questions or answers that are bullshit. Is it pericarditis? No. Absolutely not. Is it stable angina? Stable angina doesn't, it gets relieved with nitro. So it's not stable angina. This came on with exertion. So it's either unstable angina or STEMI. Now we look at those vital signs, right? Let's say he was a little hypotensive. We'll say 90 over 60. Okay, it's not good. Does 90 over 60 really matter? Nope. I just reallocate that in my head. Little hypotensive. Heart rate 120. Little tachycardia. I don't care about the number. Respirators 18. Don't really care. That's normal. So I look at it. Is it too high, too low? But I try to take the numbers out of it because we get stuck on numbers. We hyper focus. We have to reread. Who has to reread the question 12 times because fucking numbers? Me. Every time I'm like 119. No. Is it normal? Is it high or is it low? So he's too kids.
So you care about the range, not necessarily.
Yes. I don't care that he's 90. I care that he's old. I don't care that he's going to the post office. They put all that stuff in there as distractors. I care that he was working out. For that a 90-year-old, that's working out. Okay. Yeah. So old dude exertion. Signs and symptoms? Yep, check. They match being bad. I don't even care what they are. Do they match the problem? Yep. I might have to reread those to make sure, but yep, they match the solutions. Okay, check. Vital signs. Low blood pressure, so hypotensive. Little tachycardic, not surprised. Normal breathing. Good. All right, cool. Check. All that matches. Now I have to really look into it. They said he took a nitro. That's key in this. Do I have a 12 lead? Does it say anything about 12 lead? Can I diagnose a STEMI without 12 lead? Shoot, could be having, could it be the right answer? Sure could. With the information I have, can I say it's STEMI? Unstable angina it is. But there was 3 right answers. There was angina, somewhat right. Yes, he was having chest pain, but it wasn't stable angina. Unstable angina, absolutely. STEMI, probably, but we don't have enough information. I made that test question up because I've been doing this for a long time. I made it up on the fly yesterday.
Yep.
But that's exactly how they word these. And that little clue of nitro is the difference between him having a history and him not having a history. But they don't just come out and say, they used to. 10 years ago, they'd be like, has a history of. No, now they say he took 2 nitros. That's to clue you in that there's a history there. He already knows he has some sort of history. Now you have to jump through the hoops. You understand? They give you the clues. Your job is to weed through the mud. I don't care about the post office. I don't care that he's 90. I just care that he's old, because old's a little different than a 17-year-old, right? So I look at it old, young, normal. Male, female, yeah, that matters a little bit. Not a lot. Go from there, okay? Weed out shit that doesn't matter. Gain clues by inferring on things that might matter. Nitro, that might matter. I'm not an expert. I promise you I took a platinum test right now. If I took that same test you took, I think I could pass it, but it would not be fun. And the only reason I think I could pass it, A, I have a lot of knowledge in the medical group, but I've also gotten used to how to beat the test. Half of what you're doing is beating the test. So I had somebody really discouraged yesterday, like almost to the point of wanting to quit class because they did not pass the exam yesterday. But we give you 2 attempts for a reason. First of all, we know the tests are hard. We also know that part of this is learning the test. It's learning how to beat the system. I don't think I'm not gonna say nobody's deaf in this room. I don't know. But I don't think that's the problem. I don't think it's a knowledge issue. I think it's a beating the test issue. That's why I encourage people not to quit. That's why we keep working, because we want you to succeed. But you can't give up on yourself. You give up on yourself, it's a stupid test. I can't beat it. Well, you give up, we give up. Like, like we can't make you win, so. Alright, good on that note.
Yep, can you wave at the camera?
I'm John, I thought it had me. Wasn't it facing over there earlier? Alright, we're about to start cardiology. I get pretty passionate about cardiology. I like cardiology. Good, dude?
Go ahead, Tyreek.
That's good.
So before we start, one of my people that I work with that's in what cohort was Jenna in?
6.
Cohort 6. She was saying to download. Well, I bought the book, but I actually quite like it. The National Registry Paramedic Prep Caps and Medical for Cardiology, because it gives like it'll be obviously there's a bunch of ranges for you go through, but it gives you like very basic ones to look off. And she said that for her and a lot of people that she it helped out her.
Yellow book?
Well,
I think it's orange.
I think it's purple.
Oh.
I think it's purple. I don't know why, but this is the book she's referring to, the cap one. It's not so.
Here's the thing, let's go to rule 1 of cardiology.
That's a good segue,
That's
Tyreek.
perfect segue.
Thanks.
Rule number
Very
1. Don't talk about cardiology for the next 4 weeks. Don't look stuff up, don't buy books. At least 3 weeks, 3 to 4 weeks. I'll let you know. Depends on how fast we go. I'm not kidding about this either. Like, I know some of you will do it because you can't not help it. Please don't. I need, and this is no shit. I need to get a groundwork built. I need to make sure we're all operating on the same page. And I know you all work jobs, you're gonna do other things, and you're gonna want to talk about cardiology. Or buy books. Don't for 3 weeks. We have like 7 weeks of cardiology. So there's plenty of time after I get a foundation built of how we're going to analyze rhythms together to then go and do other things. But what happens is Nate tomorrow will go on shift. And there'll be some cool call. And some medic, good, bad, or otherwise, doesn't really matter, will be like, you see here, this is, that's a bundle branch block because of blah, blah, blah. We don't cover bundle branch blocks today. That's next week. But then next week we'll come in, Nate will be like, yeah, that's a bundle branch block. And I'll be like, no, it's not. And that fucking guy's an idiot. Or whatever. Okay? Excuse me. Sorry. So there's a lot of bad and there's a lot of good out there. Some of it's like, the TikTok shop has a lot of great videos. And there's some I'm like, man, this guy's allowed to have a paramedic license. And I can't vet all those for you. And sometimes you think that medic's really good. You've got that medic in your mind, you're like, man, I trust him no matter what Nick says. Just please give me 3 weeks, and then you can decide whether or not you trust him still. Okay? Because I've seen people that I thought were really good medics, and I do QI or did QI here for a long time. People Andrew thought were really good medics, and I'm like, they call this systemic. And we're like, that's what? Or they cardioverted this. And I'm like, oh my gosh. So give me 3 to 4 weeks and let's get a firm foundation where you all know stuff. You're not just guessing stuff. And then we can talk to our friends at AMR or even at JCAT. Like I would tell the same people that I'm just saying the standard's the same. I don't want our students, whoever they are, talking about because they get bad information. All right. What's the other rule? Oh, don't miss. Don't miss. Don't miss class the next 3 to 4 weeks. You're like, oh, I can do Zoom. It's not, you'll see today. It's not the same. I already lost it. It's not the same. Okay? You can't see the whiteboard. We don't have a smartboard yet.
Wait for the USDA's approval.
Okay. We don't have our smartboard yet. You can't see this worth a darn from Zoom. Okay? So be here. This is not the time to miss. Even if you got the sniffles or you're, trying not to throw up, just get here. Okay? We'll get through it together. Everybody good on that? I think it's a little passionate. All right. There's some basics we have to cover. We have to understand some basics. We understand the basics, we can move on and get into the fun stuff. It doesn't matter how slow we go. We were on slide 13 at lunch yesterday.
Yeah.
And we got a later start today. We'll be surprised if we make it. That's okay. What slide we're on doesn't matter. I will take as long as it takes. Normally it takes me 3 to 4 weeks to get through the 338 slides that we're going to do. This is what it is. The speed doesn't matter. What matters is everyone in this room walking away with the knowledge of how to read rhythms. Also, if you're scared, Tyreek, because I see your face, I don't think I've ever lost somebody in this stage.
You ain't never met somebody so just intensely.
Trust me, it's okay. It's okay. This is not hard. I can teach.
Hey, Jared's back there.
I can teach about anybody how to read these rhythms. I really can. As long as you work with me. Listen. Okay? I feel like there's one other thing I was gonna say before we got into this. Speed doesn't matter. We're gonna do this for the next 3 or 4 weeks. We talked about that. Yeah. Okay, the hell, let's go. What 3 things, some of this is gonna be reviewed from AD, but that was a long time ago, so we need it. Oh, that was what it is. I review each week. So this week we're gonna get through maybe, if we feel good, slide 104.
Yeah, I think I wrote it down yesterday.
Okay. As long as we catch up to yesterday. And then next week, the first probably hour to 2 hours, we'll be rehashing the first 100 slides. And then we might make it to like slide 179, 200-ish on week 2. And then week 3, we review week 1 very quickly, week 2 less quickly, and we get through week 3. And then week 4, which is I think about where we'll finish the PowerPoint probably, or maybe we're finished already, we're gonna review weeks 1, 2, and 3. And then I hand you off to one of the other guys to start building on the foundation we built. The other thing is you're not gonna be cardiologists after these 4 weeks, or after ACLS. The first, this cardiology section in paramedic school, we get you a firm foundation. And then at the end of the program, we rehash some of it a little bit more in depth. So you're gonna have a really good, probably could compete with your field medics knowledge on cardiology, if not beat them by the end of this 7-week time frame. You're not gonna be a cardiologist. You might be like, well, Nick didn't teach me that sprinkle. I have one student, he's not Meg, love him to death, super smart. Could probably read you a book without looking at it, smart. But he's like, but you didn't teach me that. I'm like, because not everybody's on your level and I can't teach you everything because I'm teaching to 30 people. So you're not gonna learn everything in this class, but you're probably gonna be able to compete with your average medics on the truck. Unless you got that one super autistic smart person, okay? Good. All right, here we go. 3 systems we need for the heart to work. We're talking about the heart here. What 3 systems do we need? Okay, we do need oxygen, in and out. We need blood. We need blood in the heart. Okay, we're going to build on that. We need blood in the heart, in the pump. And we need blood, oxygenated blood. You're right. In the artery, the coronary arteries. That's one portion of this. If we don't have the blood flowing, either the volume in the heart, in the pump, or getting to the muscle itself. Because remember, the blood inside the pump, inside the muscle, does not oxygenate the muscle. It gets squeezed out like a rag. Remember, the heart kind of sits there and it twists. As it squeezes, it twists, and it squeezes out blood. That blood inside the heart, whether it has oxygen or not, doesn't help the heart muscle live. Okay? The blood that comes to the coronary arteries on the outside wall of the heart, which I'm going to show you in a minute, that's what keeps that heart perfusing with oxygen, keeps the tissue alive, allows me to say that here. So we need blood, both volume and oxygenated blood. What's next? What other systems do we need? And it's not like body systems. We're just talking about the heart. We need electricity. So we need the electrical system to work. These aren't necessarily in any order. We need the electrical system to work. Okay, and that really goes back to the sodium potassium pump, but we'll just put electrical system for now. Okay, third thing. Some part of this has to make it all happen. You can have this. And you can have that, and this guy not work, and that person's real dead. But we don't actually need the brain.
Well, this is exciting.
That kind of comes back to this one.
Okay, my bad.
Don't
Stop.
apologize, dude. It's back to you. Think about our patients. What kind of cardiac arrest patients do we run? What do we run? We run V-fib, we run V-tac. What else? Asystole or what? PEA. What happens in PEA? Do we have blood in the pump in PEA? Most of the time, yes. Depending on what happens. Do we have an electrical system working in PEA? Turns out we do. Pulseless electrical activity. The electricity is fine. What is not happening in PEA? The muscle is not moving. We need the heart muscle to cooperate here. So no one of these three things, no particular order, we need all three to happen. We have to have blood both inside the pump in volume and outside in the coronary arteries. We have to have a working electrical system. And that's not just sodium potassium, but yeah, that's there. And then we have to have the heart muscle cooperating, working with it. When those three things happen, we have a heartbeat. Do you have, somebody said the brain, good point. Do you have to have a brain? Think about our guy, we called you a 21-year-old airman.
It can still beat without brain activity.
Yep.
You can hear it.
Yeah, for a little bit. It's the oxygen that gets the heart pissed off. So we get called the airman that shoots himself in the head. And I go with airman because that happens a lot here. Just situational. Shoots himself in the head. We get there, if we get there fast enough, what's happening still when we get there? Could be brain matter just everywhere. Sometimes the heart's still beating if we get there fast enough. When is the heart not beating? Lack of oxygen. Lack of blood or lack of oxygen. Ironically, a lot of times those GSWs, the head stop bleeding somehow. I don't necessarily, I think maybe the brain matter like goos it up or something. I don't necessarily know why that is. So it's not normally that it's a lack of blood, it's normally a lack of oxygen. The non-breathing for such a long period of time before we get there. But if we get there quick, that heart is still beating most of the time. Or it's in a rhythm that we can get back. So what do? Well, most of us have protocols that say, that's not compatible with life. Today. I do think that maybe some of your departments should look at those protocols and say, hey, can we keep that heart alive and go transport them up to the city, and then they can be donors and donate to like 30 people. But that's a conversation for a different day. The reason why the heart's still alive is it has this thing called automaticity. We'll talk about that later. Oh, there's a lot of times today where I'm going to say, great question. Not right now. So don't take that the wrong way. Okay? I had to do that probably 50 times yesterday. That's great. Good question. We're not talking about it today. Why? Because I'm managing all of us learning, and we're learning at the same rate, and we'll get there. And we're going to build a foundation before we get there. What?
Write them down.
Well, I'll take questions. You write them down for the future if I can't take them today. That's a good point. All right, when we look, we're going to use these different screens. Okay, so we're going to use that screen a lot, and then the rest of the time. Those coronary arteries run on that outside wall. Okay, remembering that that's where we get perfusion to the heart muscle itself, the outside wall. Okay, and then inside is where that blood is flowing through the pump. And when we look at the heart, it's showing its face. What does it show us? Because it's not straight on. It kind of is canted. So what are we looking at when we look at the heart straight on? When we look straight on, what are we seeing at the heart?
Like what anatomical structure?
What part of the heart do we generally look at? Let's do a 12 lead. Standard 12 lead. What are we looking at? Left side. The left ventricle. We generally, the heart is canted a little bit. The right is kind of pushed backwards, and you're really facing on at the left ventricle for the most part, which the standard 12 lead looks at the left ventricle. Standard 12 lead only gets about 85 to 90% of heart attacks. It's looking at the left ventricle, and not all heart attacks happen over here. Okay, so we'll talk about that today too. There's some background slides we have to get through, a little bit of background information, and then we'll really be popping on fun stuff. This really just warms my heart. The first freaking word of the first slide is an abbreviation of a word we've never seen before. It just pisses me off so bad. I hate abbreviations in slides. I don't think they should exist. CVD is cardiovascular disease, but they're going to start off with an abbreviation just to make it mad. Refers to a group of disorders of the heart and blood vessels. Coronary heart disease is the disease of the coronary arteries. These are some big generic terms. I'm not a huge fan of generic terms, but I will teach them to you to make sure you know the big words when you have to. There's another one, AMI. What is an AMI? It's not an alternate day at school or whatever they call it these days. Acute myocardial infarction, okay? So acute myocardial infarction, heart attack, things we look at quite often. It's a narrowing blockage of a coronary artery. Causes myocardial tissue death. One person in the United States every 40 seconds. This is why Johnny and Roy were originally created. Heart attacks and out of hospital cardiac arrest. That's why we started paramedics way back when. To solve that problem. And then cardiac arrest, the cessation of cardiac mechanical activity. These are the words they use in the test. Cessation of cardiac mechanical activity. You know what cardiac arrest is, but if we say those words, do you know what cardiac arrest is? So if I said, what is the definition of the cessation of cardiac mechanical activity? Because that's the way they word this. And then I put a bunch of different answers up there. Would you know what that means? What if we said the answers are PEA, cardiac arrest, asystole, or VFib? Cardiac arrest, because it could be any of them. But they're all right answers. Some of them are just not as right as the other one. This is the way it is. Whether we like it or not doesn't really matter. We're not in charge of the stupid tests. You say, well, Nick, you could use some of the platinum. I absolutely could. We can go back to FISDAC where all the answers are on Quizlet. And you can look them up and you can pass my class and then not pass registry. We did that once and we learned. I'm using platinum. We use platinum. All these other schools use platinum because it's the closest thing to registry rate. Someday that may not be true and we'll adjust. But right now, it's the closest thing to registry and we want you to succeed. Most out-of-hospital cardiac arrests occur in the home of residents, and then we go out and treat those. Today, next week, the following week, we're not going to hit on treatment a lot. We're going to really focus on how to identify and determine rhythms and some of the background of what causes the rhythms to be off. And then as we gear up for ACLS, and we'll talk about treatments, don't get me wrong, but as we gear up for ACLS in like 5 or 6 weeks, we're really going to gear up on treatments as well. All right, so we're looking at our anatomy. Cardiovascular systems compose the heart and the blood vessels, delivers the oxygenated blood to nutrients and cells. Help me remember, that red blood cell, okay? Let's say he starts at the lungs. What's he picking up in the lungs? He, she, it, they. What is that red blood cell picking up in the lungs? Oxygen, right? It's oxygen, so it's going to put that oxygen in this red blood cell backpack, and it's going to leave the lungs and go through the what? Pulmonary vein. Pulmonary vein. If we remember arteries are always away, it helps. Arteries always go away from the heart. So it goes through the pulmonary vein into the left atrium, leaves the left atrium and goes to the left ventricle, leaves the left ventricle and goes out the aorta. And then where does it go? Wherever it wants, right? It goes out in any direction. And it gets to the hands of the feet or wherever it is. Gets down to those cellular levels, wherever it's going, and does what? Yeah, it takes the oxygen out of its red blood cell backpack, drops it off the cell, picks up the CO2, puts it in its red blood cell backpack, goes through the veins, okay, to the, yep, it's going to go to the right atrium, and out of the right atrium it goes to the right ventricle. Good work. We have less energy today.
Yep.
Out the right ventricle through the pulmonary. Arteries are always away. Pulmonary artery to the lungs, drops off the CO2, picks up the oxygen, and does it all over. If we don't know these three systems and what I just said, we gotta get it committed pretty quick. Okay, we have to know how that process works.
Is there like a diagram or a picture?
You want handies up?
You don't have to color anything. You never have to color in this part. If you want to color, you can color. You don't have to.
Actor on the art. That is me.
All right. So there's their picture in the book. There's my picture. I like my picture better. Mine does move. It does a lot of cool stuff comparatively. Okay. Everything we just said is up here. Okay, everything we just talked about is on this slide. You know, I used to say you don't necessarily need to know the valves, and then I saw some valve questions. So you probably need to know the valves. You need to know the aorta, and you need to know, you know, the vena cava. You got to know those structures. This is something you could review in your off time. You can stare at, but I think it's really about can you tell me what I just said to you? Can you tell me the path of the red blood cell? Because if you can tell me the path of the red blood cell without me telling you, you got it. That could be a quiz. Tell me the path of the red blood cell. Starting at the lung. Yeah, archetypes. So a lot of how I teach is I'm gonna talk about it. We're gonna whiteboard it, and then we'll review it on the slides. But we're probably gonna go through a lot of slides quickly because we've already touched it. Okay? That used to freak me out as a student. So if you're freaked out, it's okay. I promise you, because of our visual learning nature, your learning goes way up when you're not reading slides. When you're actually just discussing things. It freaked me the F out. I had my paramedic instructor didn't use slides. It was all Google Notes, and he'd just draw on the board, and I lost my mind. And then about 4 weeks in, I was like, I'm actually learning, so I should shut up. So, the septal wall separates the left and right side of the heart. Okay, that wall in the center there separates the left and right. Sometimes, like kids can have septal wall defects. What kind of heart attacks can somebody have? Somebody name a type of heart attack. VTAC is a rhythm. So inferior, yes, good. Inferior. What does that mean? What does the word inferior mean? Yeah, all what I'm trying to get at is when we hear things like an inferior MI, it's referring to a location in the heart. A septal wall MI, it's along the septum. Like an anterior MI, in front, right? Lateral, the left wall. It's literally left lateral. So we trip up on those things. We don't necessarily think it's just using terminology to describe where, especially in the left ventricle, we're having the MI at. You don't have to freak out about it. It's okay. Which side of our heart is the strong side? Left side. They remember that. I had to yell at them, but they remember. Left side, strong side.
Remember the Titans.
Remember the Titans. That's right. Left side, strong side. That and Josh Darren. Left side, strong side. The left side of the ventricle supplies blood to what? The whole body. Remember, our heart is a pushing pump, not a sucking pump. So that left ventricle pushes out blood to the systemic circulation of the whole body. And where does the right ventricle push blood to? Through the lungs to the left atrium. That's it. Now, this always trips people up. I couldn't find my handout on this. It's kind of disappointing. I'll have to find it. When one side, let's say the left side fails, left ventricle fails. So the right ventricle is just going along its normal, just doing its stuff, right? Let's say it's beating 100 times a minute, it's just doing its thing. And it's pumping its maximum GPM for you firefighters, maximum amount of gallons per minute. But the left side still beating the same rate, but it's not getting a good squeeze. It's not got its GPM up, you know, it's pumping like 50 GPM. What's gonna happen? Where does it back up to if the left side fails?
Would it buck in the lungs itself?
Into the lungs. Good. Most people get tripped up on this. The left side fails, left lungs. Left side backs up into the lungs.
Oh, that's why when you have
Left lungs.
CHF, that's why when you have CHF, if you're having right side heart failure, it's always going to be left side also. Is that right? Correct?
I understand where you said.
That's why when you have like CHF, like from like getting COPD, if you have right side heart failure, you're automatically going to have left side heart failure. Like those two things don't hang in, right?
Not necessarily. If you have
No.
right-sided heart failure, we're not like as super concerned about it because it just has to go from the heart to the lungs and then back to the heart. So it's not a high pressure side. When you get the left-sided heart failure, both are bad. No, left side is worser because that side has to get the blood to the rest of the body, and if that starts to fail, then it backs up into your lungs, which causes.
I think I know what you're saying. Hold that question. If the right side fails, our low pressure system, where does that back up at? Edema in the hands and the feet, right? Because remember, left side's going full bore 100 gallons per minute. Now the right side's only doing 50 gallons per minute. Oh, I'm making these numbers actually clear. All of a sudden, if it's not doing the same volume as the left side, it's got to go somewhere. It goes to the hands and feet. Okay. there's a high correlation of when you get left-sided, it's in the lungs, the right side, which is the weak side, will eventually fail too. Okay, there's easy correlation. Do you guys have anything you want to say? Your face looks like you had issues.
No, it does.
Yeah, I know, and he gets stuck out like that sometimes. All
Go
right,
on, you can. Yeah, we'll keep it there, because otherwise you'll be.
yeah, we're day 1, minute 5. Myocardium is the middle layer of that heart wall, composed of thick muscle tissue, and it's responsible for that cardiac contraction, that efficient squeezing. And remember, the heart kind of twists as it squeezes. It's really crazy to watch a heart beating like on a table, because you can just watch it do its weird jerky motion, right? It's responsible for cardiac contraction and efficient injection of blood from the heart. Yeah, we'll wait on it. Remember, those coronary arteries go down the outside of the heart, okay? And I have a coronary artery picture, I think, coming up. But the main coronary artery on the left side is the left main coronary artery supplies the left ventricle and part of that septal wall. The right coronary artery supplies the right atrium, right ventricle, and part of the left ventricle. And when I get to this picture, you'll see what I'm talking about part of the left ventricle. But let's see. Where's that picture at? Andrew, where's that picture at?
Which one?
Never mind. I'll have to go backwards. I did this a lot too. If you're like trying to keep up, don't worry. All right, here we go. Perfect. Thanks.
You're welcome.
Super helpful.
Yep.
Maybe one more. No, that was it. Okay. This left coronary artery starts up here, and then it becomes the left anterior descending. You guys ever heard of that LAD? What's the LAD known for? If you get a blockage to the LAD, what's it called?
Widowmaker.
The widowmaker. Can you see why? This sucker is huge. And it supplies there's other things that come off of the LAD, but it supplies the vast majority of the left ventricle. So you get a big blockage, a high LAD occlusion, yeah, no wonder people die. Like, obviously. When they say you can get collateral circulation, well, they didn't say that. They said sometimes the right coronary artery supplies part of the heart. When it reaches around down here at the bottom, sometimes you can get, this drives Andrew nuts, but that's okay. You can get what we call collateral circulation. So if there's a blockage where I just circled, you're welcome, buddy.
Can you
If there's a blockage right
get
there,
on the USDA? Thank you.
But the president just froze everything yesterday, so.
Hey, think
everybody's
about it.
paying
You might
for
owe me
major
money
one.
back.
No, it shouldn't.
No.
That's what the people at the USDA that are laid off right now. Thank you. There's a blockage here. Sometimes our heart can reach around with this. It's the right coronary artery, but it breaks off down a smaller artery, and I think it's the intermedius radius, whatever. It can get some collateral circulation to that area. What would normally be a big old heart attack, and they're having STEMI, they may just be having some pain, some stable angina maybe, because they're still getting oxygen, enough oxygen from another artery. That's called collateral circulation. We'll talk more about it, but that's kind of interesting. So I used to say you didn't have to know the arteries, because you used to not have to know the arteries as a paramedic for which artery is what. You just had to know what part of the heart was being affected, inferior, all that good stuff. There's artery questions now on the test, so. And you might say, Nick, this isn't fair. You're damn right. The test is absolutely harder today than it was 5 years ago. And you know what? 5 years ago, the test was harder than it was 15 years ago. They expect more out of paramedics. We do a harder job than they used to.
It's probably like, can you start an IV? Okay, cool.
Where do you take people to the hospital? Yes, good job.
Paramedic.
Can you start an IV? Check. Check. All right. Coronary artery, we just talked about that. It's important to note that right coronary artery supplies the electrical system, or at least the vast majority of the electrical system. So sometimes we'll get a patient that's having all these funny little beats going off, FLBs, that's not a technical term, that's a Nick term. And it's because it's the right side, not the left side. All right, some components here. What do these mean? So we're gonna start with automaticity. We already kind of touched on automaticity a minute ago. What does it mean that the heart has automaticity? It's automatic, without brain control. We do not need the brain to tell it to beat. The brain, spinal cord can be severed. I see spine fracture, and if we're still breathing, even though the brain's not being communicated with, I'm sorry, the heart may not be communicated with, we'll be okay. If we stop breathing, guess what? Eventually the oxygen issue is going to cause us an issue. If you, me, other paramedic heroes get in there and innovate and give oxygen, that heart's not going to stop. It will not stop because it's automatic. That's automaticity. Now, it might be a little slower than we want it to be because it's not getting that spinal cord communication from the brain. That could be a problem. Depending on what kind of spinal cord issue, we might have spinal shock where we don't have a good enough blood pressure, like neurogenic shock. That could be an issue, not enough blood flowing through the pump. All these things can cause other problems, but on its face, the heart will keep beating as long as we manage the other issues. Okay, that's automaticity. What's excitability? Excitability.
How, I'm assuming like the rate at which it could like increase your heart rate's like activity with the excitability, like if you want to work out or something.
So like you get a bee sting of some kind, your heart goes to pump faster to fight off what's the infection.
Yeah, kind of. Not that your heart knows it. Your brain can tell it to speed up or slow down. So excitability is the concept that the heart can respond to external or internal forces being put upon it if the brain tells it to, basically. What does that sound like? What part of our body, what system speeds up or slows down the heart? What? It's okay to say it. No, not that. The brainstem control, this word control, this generally happens at.
Like sea calls, like whatever. Like.
I'm not saying where, what system
Oh.
speeds you up, tells you to fight, flight, or freeze, or slows you down and tells you to rest and digest. Isn't that it? That's our fight, flight, or freeze, right? Yes? Put that up here. Fight, flight, freeze. This is what engages right now if somebody walks in the door with a gun. Okay? We're all going to have a sympathetic nervous system dump. What about in 2 hours after lunch and you're all tired? What system's engaged? Parasympathetic. Remember, I relate these to dimmer switches. You got a knob over here and you got a knob over here, and you can control them independently. You can turn the parasympathetic system up or down. And by down, we're really blocking it. But there. You can turn it up, you can excite it. We're going to talk about what happens on each of those. Okay. If we excite the parasympathetic nervous system, the rest and digest system, what side effects, what symptoms might we see? Hey,
Decreased heart rate?
say what?
Decreased heart rate?
Yes, decreased heart rate. When the old man on the toilet pushes too hard and he excites his biggest nerve, he excites the parasympathetic. He's always naked, by the way. He excites the parasympathetic nervous system. So when you get there and he's passed out unresponsive with a heart rate of 40, what he did was he bared down so hard, excited his parasympathetic nervous system, and got a heart rate drop. There's a drug for that. So we get a heart rate drop. We can get what happens in the lungs. Not so much with rate. You get bronchial constriction. We get increased salivation, saliva/mucus, and pupillary dilation. Is that what we said? It's from yesterday.
Can
Look it up again. No, you're not ready.
no, I super am.
I love doing shit. All right. We don't have any meds.
They constrict.
They do constrict
Mm-hmm.
with parasympathetic?
Mm-hmm.
Yeah, got it on answer. All right.
Sympathetic,
Silent.
because you need to see the danger.
Yeah. All right, the opposite of this, if we block this out, we could get a heart rate increase. We could get bronchial dilation. We could get decreased saliva / mucus. Could get some pupil dilation. Okay, let's talk about sympathetic, and then we're gonna bounce back over here. Same thing, we can make it go down, and we can make it go up. If we make the sympathetic nervous system dial go up, what are we gonna see? We can see an increased heart rate. What else?
Bronchodilation, take on more oxygen.
Bronchodilation. What else?
That's all I got.
Arterial constriction. Pupils dilate. Okay. We block it, basically the reverse can happen. Okay? There's some really big words you have to know. You guys remember any of the big words? We want to turn this up. What's a big word for turning it up? There's 3 of them. What? Big word for turning up the sympathetic nervous system. Sympatho.
The medic.
Yeah, we're gonna medic it up. It means mimic. Pathomimetic.
Oh.
Adrenergic. Adrenergic agonist. Or sympathetic agonist. Let's talk about the big words for turning it down. Sympatholytic. That means to block out. Adrenergic. Antagonist. Sympathetic antagonist. Very important that we commit these words for our memory, because guess what? They'll be on test. Now we have a lot of drugs in this realm, folks. We have drugs on our ambulances that do this stuff. What drug you carry on your ambulance focuses specifically on turning up the heart rate? Epi is the best example of a heart rate increaser. Its primary job, Epi's primary job is a rate increaser, a chronotrope. What does chronotrope mean? It's rate, the rate. So Epi has got a chronotropic drug. Sometimes it says chronotrope or sometimes it says chronotropic. Once again, big words will be on test. So I want you to know the big words. There are different receptor sites here. Okay? What receptor site is Epi working on when it increases heart rate? Remember, I'm going to help you out. There's alpha 1, beta 1, beta 2.
No, 2 lungs.
Beta 2 is 2 lungs, 1 heart, beta 1, 1 heart. So when we use Epi on the heart, it's beta 1, 1 heart. Good. Everybody still with me? I haven't lost anybody? This is just review. This is A&P review. You haven't really gotten into slides. Bronchodilation. What drug do we have on the truck that causes bronchodilation? Albuterol. Good. Anybody want to say Doonav? Did yesterday, they were wrong. Albuterol is the right answer. What receptor site does albuterol work on? Two lungs. Does albuterol have any beta 1 effects? Do you ever see your heart rate keeping up when you're giving albuterol after albuterol? Sure does. It's a primarily selective receptor. However, it has some bleed over, so we can get some heart rate increase. Not a lot, but some. Albuterol is a beta 2 agonist. It's going to increase it. Give me an example of something that causes arterial constriction. If you have any of those right now, there are probably 2 things. Levothed, yes. Levothed or Epi has some of this, but it's not primary. Primarily, Epi's rate. You got it. Silver bag on the shelf. Don't use it very often. The chart with it, it's hard to use.
Starts with a D.
Does. Not carded, then starts with a D.
It's the yellow pocket.
Dopamine.
Yes. You guys are just describing all that. Silver, it's in a yellow thing. That's over there. This thing.
So levothed and dopamine are primarily hitting what receptor? Use beta 1 and beta 2. I told you 3. Come on. Alpha 1. Yeah. Okay. Alpha arteries. Primarily it's hitting alpha. And you're like, but Nick, Epi has some slight arterial constriction. It does have some. But it's primarily a heart rate. Primarily a chronotrope. Meanwhile, levothed has some heart rate, but it's primarily a inotrope. Inotrope, levothed / dopamine are primarily inotropes because they increase the pressure. Now, there's a whole debate. We could probably duke it out in here for 4 hours on the benefits of Epi versus dopamine versus levothed. Epi has high cardiac oxygen demand requirements because it's increasing the rate. Levothed has very low cardiac oxygen demands because it doesn't increase rate much, as long as what? The container's full. Here's what happens with levothed, is why it's needed to leave them dead. If you don't fill the container first, it squeezes the arteries down so much that no blood gets through. The heart starts, and then it has an issue, right? It collapses the hose line, fire truck. Okay, how do we prevent that? We get full boluses. So I'm 225, 230 pounds. We'll just call me 100
Jesus.
kilos for 100 kilos. Okay, how much fluid do I need for a full bolus? 20 milliliters per kilogram. How many? What?
10 to 20 per
20. Stop saying 10 to 20. 20.
Well, that's what we.
10 to 20.
Cross that out.
The 10 side is great for kids. 10 to 20 for kids. Okay, or people with heart problems. 20 mils per kilogram. 2,000 milliliters. 2 liters. One bolus for me is 2 liters. 97%, 99% of our population, including probably most of you, walk around in a dehydrated state all day long. 99%
Not
of
Tyreek.
Americans.
Tyreek doesn't.
If your pee isn't clear from the time you wake up to the time you go to bed, you're in a dehydrated state. Sure. So, everybody can take a bolus. How do you know if somebody can't take a bolus? Well, they have congestive heart failure, they have fluid overload, you'll start hearing it in their lungs. What do you need to do then if you've gotten that far? You probably need to buy tap and control. It's controllable. It's fixable. I'm not saying wet people down so much that they're spewing fluid at one time. But here's what, there's a mentality, and your medics probably have it too, your hospitals probably have it. We'll start a 500 bag, or they'll set the 1,000 bag on a pump for the next 4 hours. That's not a bolus. That's a leakage strip. Okay, that's because you don't want to have to drink water.
So the goal is more so like fasting,
I mean, relatively, yeah, like
I'm sure you don't know.
yes, I'm not trying to be like you turn it on and you let it flow. So I could take a full bolus, and you can repeat that on me as needed. As long as my lungs are clear, I can take another bolus. 4,000. 4 liters. I'm gonna pee all day long if you do that. But you could. So you have to fill the container before you can squeeze it down with leave. I do like dopamine. It does have some cardiac oxygen demand. However, it's a good short-term drug. I've got a patient crashing right now. Okay, I could give some dopamine to start the squeeze, fill the container, and then switch to leavothyroid when we get to the hospital. I like that. Not everybody likes that. Do what your local protocols say. I don't care enough to fight about it today. Maybe no more. 'Cause I can just see Jared ready to go back there. So
I think he's just looking at his phone.
no, I don't. Shit. All right, on the opposite side, we don't necessarily give out these meds. Name some meds that decrease heart rates that we see our patients on.
Yep.
What?
Yeah. The beta blockers.
Okay, our lulls. What are lulls? What? I thought you said left on it. Beta blockers.
I did.
Beta blockers are things our patients are on. They end in LOL and they decrease heart rate. They don't go after the arteries, surprisingly. How do we know that our beta blockers go after heart rate? Well, beta 1. It's going to go after heart rate. You would think if blood pressure was high, you would attack it by going after the arterial constriction. It's easier to decrease the heart rate. So these are the folks we see, they're like, I'm in 10 on 10 pain, like their heart rate 60. They're in 10 on 10 pain. Because you can't see their heart rate because it's artificially decreased with beta blockers, okay? They could also cause some slight bronchoconstriction because it's beta 2. It can happen. Doesn't necessarily happen all the time. So you might have to give it, not leave it off. These arteries where am I at? Arterial dilation is going to do what to blood pressure? The hoses get bigger with the same amount of stuff in it. Decrease blood pressure. So sometimes when beta blockers don't work to control blood pressure, they put them on alpha blockers. And alpha blockers end in OSIN. OSIN. But you can see patients on beta blockers and alpha blockers. So heart rate controlled, that didn't fix blood pressure. They also put them on alpha blockers. Okay? So we can see our patients on these things.
What's a med for that?
Oh shit.
Thumaslocin or something like that. It's Flomax. That's the most common one. Huh?
Camulocin.
Yeah, whatever. So, something like that.
Okay.
I can't ever say those ones.
Here's the other thing. When I talk about these drugs, and this is, they don't just do these things. So pupils constrict and all that stuff. Like, what does Flomax do?
It's a smooth muscle relaxer.
So it can have, that's what I'm getting at. It can have other effects. So it can have people urinating. So it just depends. Okay. Let's switch sides. Give me the big words for parasympathetic if we're trying to excite it. Cholinergic, what?
Damn it.
You said it.
Come on, man. Just say it. Just say it. Say it, be wrong. Just say it. I did text Odell and say stop talking.
You're on mute. You're on mute again. And Mike Martin was going too, so you would have felt right at home. Cholinergic what?
Just go, say it.
Cholinergic what? On this side, is it agonist? Agonist. Let's go. Or a parasympathetic. Same side, same words. Miss parasympathetic agonist or a sympathomimetic. On the opposite side,
So then it'd be
parasympatholytic. Agonist. Cholinergic. Antagonist. Cholinergic antagonist. You don't know how hard this is. And a parasympatho. I'm sorry, parasympathetic. Parasympatholytic, right? No, we already did that. Parasympathetic antagonist.
You also sometimes see anticholinergic.
Yeah, anticholinergic would be fine too.
Is that like?
Not cholinergic.
No, I know, but is that?
It's
Yeah.
it'd just be over here.
Yeah, all those are the same word.
Oh, okay.
All those mean the exact
These all
same
mean
thing.
the same shit. Okay.
Yeah,
But
but
this is what they're gonna. Right? They're gonna say the patient's taking a cholinergic agonist, they probably won't even give you the maybe they will, some medication name. They might say they're having these side effects. What is the fix? And they're gonna say a parasympathetic, well, wouldn't it be the same thing? And they might say a cholinergic antagonist. Well, one of these words is the right answer, you know, and they might throw some of those answers over there. Sympatholytic. Guys, it's tricky. It's tricky. None of these, we don't really have any drugs over here that we give on the ambulance. We don't want your heart rate to go down. We don't want your bronchioles to constrict. We don't want you to salivate more, ever, really. So we don't get meds here.
No question, like, when would you?
So these are normally things we see. Give me an example of something your farmers can come across that's gonna cause this shit. Anhydrous. You're gonna get this kind of stuff.
toxic shit.
Toxic chemical inhalation causes this stuff. Not good. Now, us, what do we give that blocks, phosphate, yeah. What do we give that blocks out the vagus nerve on the ambulance? Dude pushed so hard, he shot himself and passed out. Very good. Atropine is one of these words. Okay? Atropine, very good. What do we give on the ambulance that blocks out bronchial constriction? Don't say doing it, we'll smack you again. It's the partner with albuterol, epitrophin bromide, or Atrovent. Same drug. I'm gonna write Atrovent for my own ease. But it's a blocker. That's right. This is also why we only give one Duoneb. Okay, I know some of you have different protocols, but there's only need to give one Duoneb. That Atrovent lasts 3 to 4 hours of blocking it out. So I do the Super Troopers thing. I'm already pulled over, I can't pull over any further. I'm already blocked out, I can't be further blocked out. Now we're just adding medication. And so sometimes I'll get atropine to get some decreased salivation and those other things as well. Glucagon is also used as a smooth muscle relaxer. We can work on some of that as well, which is a weird bit of knowledge, doesn't really matter for today. All right.
With racemic also comes.
Racemic epi. It's going to be having more beta 2 effects than beta 1. But it falls over here. Cool. So we talked about automaticity, back to the slide that we left 4 hours ago. We talked about excitability, and when we got on excitability, we went to the central nervous system, all that. Conductivity, what does conductivity mean? Yes, electricity.
Huh? I know.
Because
Because he drinks a gallon.
The ability for the heart to conduct electricity. And I forgot this earlier, so we have to go over it. Do you guys need a quick break?
Yeah, I need to eat.
Quick break. We're not going to lunch yet. Take 5.
3 minutes.
I need to.
3 minutes.
I'll hold it.
Don't let me forget conductivity.
Conductivity. Got it.
The heart's conductivity. I might pee too, actually.
That's probably a good plan.
But I don't want to get distracted and forget and kind of come back.
I'll fall.
I can fall.
Never mind. I stopped saying. Stop talking.
I'm interested to see children. I was looking and it does not show anything about how.
See, but you'll be able to see our property.
It's called parcel. You can see it's all public record. There's not been a mortgage. So you may be doing like a rent to own, where the owner finance, like they're just paying. So actually owns it, but no.
Yeah.
I'm not gonna lie, dude, I feel good, even though I failed that test. In fact, I got a 69, I'm like, oh, I only one off. I'm not as stupid as I thought I would, you know what I mean?
He's probably wants to answer here, he's listening.
That's why I don't be like saying stuff, cause I'm like, oh, if I got that makes sense.
I got the leave it, I was like, yeah. I said, come on, he's like, starts with the D, I'm like, all right.
Dude, whenever I had a corner, Dick, I was like, oh, fuck, I'm so wrong. So write it. Whenever I asked my question about the heart failure, I was like, oh shit. Because they didn't understand what I was saying, I was like, oh god. I gotta explain what I'm doing about.
Looks like it's pretty neat.
I don't know how to explain this better. That's why you're here, so let's explain what's seen.
I forgot, but I'm just move on.
Whichever one you're looking at. Literally just ignore it while they're talking.
Opposite of the autistic smart guy.
I'm just the honest.
I'm the one that licks the windows.
I got autism and then it's good power that come along.
Don't stress that we only got.
Yeah. Okay, we were looking at my shit yesterday, and I got another shit.
Hopefully we get this the next couple days, it's going to be.
Yeah,
But he's still.
In the other next week.
So
that would be straight.
You know what? Some people got it, some people don't. I'm one of those, I don't got it. We went to a.
I think that the end is like
25, really?
At the end of next week, we got kind of like.
Obviously.
You go to the
Like,
yard, like maybe.
He's another one that don't got it.
He's completely lacking it back
Yeah,
there.
he's my guy.
Technically,
He's literally completely wrecking.
it's because I can't close down.
He just-
All the sex all shit.
He didn't get the superpowers. He's also really.
I want that Elon Musk autism.
Exactly, you know what I'm saying?
But I said I got this.
I want that Mark
Trying to
Zuckerberg.
just start-
I want the money that comes with complete social media.
Alright, conductivity. I meant to mention this earlier. When we look at that EKG, what are we seeing?
Electrical activity.
And that's it. So why do we see changes when there's problems? Why does the electricity change when the heart has a blockage?
It's
That's how you pull it down, is that proper?
Do it?
Can we pull it down?
Emily said it.
Nope.
rerouted, the electricity,
Why?
because like if one node isn't firing, like that same node isn't firing, then it goes to the AV node.
That's true, but I'm talking about, let's say there's a heart attack. So remember on the outside wall out here, one of these arteries has a blockage. What the hell does that have to do with the electricity that flows through the inside? Why do we see ST segment elevation on the monitor when the inside blood's flowing fine? Conductivity. Yeah.
Rerouted.
Why? Because think about this table or a rock. Does electricity flow well through a rock? No. So the tissue becomes unstable. It doesn't like to conduct electricity when it has a lack of oxygen. It becomes unstable. And the electricity doesn't flow through it well. And so it goes around it. And we see the electricity taking an alternate pathway to get around the issue.
I'm not gonna lie, can you re-explain that? I'm
Yes.
lost, because you said on the outside, I was like, okay, I'm there, and then once you said.
So the electricity flows to the inside of the heart
Oh,
as electrical pathways.
Yeah.
Okay, it doesn't care that there's a blockage of blood flow in the outside artery. It does not give a shit. My dumb self, when I was a med student, was like, Oh yeah, it just flows through the blood, like the electricity in the blood, they just hang out, no, it's not right. But I had no idea, nobody ever explained it to me. The electricity flows through electrical passageways. When the heart becomes ischemic due to lack of oxygen, due to the blockage outside, the oxygen flowing coronary artery gets blocked. It doesn't care about that. It cares about that ischemic tissue that it can't put electricity through well. Now the electricity goes around that unstable ischemic tissue. And what we see is electrical changes on the monitor.
What does ischemic mean?
What's ischemic mean? Lack of oxygen. Tissue damage due to lack of oxygen.
Now, I'm understanding.
Infarcts is tissue death. Tissue dies. And interestingly, a lot of times the electricity will travel through the dead tissue better than it will the tissue damage.
Okay, that's what I was about to ask. I was like, can the electricity not go through the dead tissue?
It does. It goes back to a relatively normal looking beat after the tissue death. So what we see in a STEMI, when it does the funny stuff, we see the damage, the ischemic tissue, it's going around it.
Oh.
Basically, that's the best way I can explain.
So as it's dying, it doesn't conduct it very well. Once it's dead and you're done with the heart attack, your blockage got opened back up, whatever it ends up being, right? After it's dead, it kind of reasonably kind of goes through it again at the same time.
Now we can still see previous damage because there's things, but I'm not getting into those things. Okay, but I need you to know when we look at the EKG, we're looking at the electrical system, how it's flowing through the heart. We better get back to what we got. I might get way too far ahead of myself. Good? You okay? You lost? Yeah. It's okay. Let's keep going and we'll come back to that. Because we're gonna talk a lot about how that thing works and what it looks like. And so I just don't want to get too far off. The last thing is it has contractility. That's that heart being able to stretch and squeeze. Mostly we're talking about the squeeze part with contractility. Has the ability to squeeze the blood out. Okay. And there's a certain law I talked about in A&P, the name of the bird. That law talks about the ability to stretch and squeeze. Starling's law. It's like a starling bird can stretch its wings out, stretch and squeeze, Starling's law. I just want to remind you of that because that'll surely be on a test somewhere. We're behind yesterday, but I almost feel like this is a really good.
I feel like we're,
Good place to stop.
you wanna stop here for lunch?
Well, that's what I was thinking,
What's
because
next?
this essay note, AV note, that'll take like probably 45 minutes.
Yeah, let's stop here.
And I don't want to stop another bit.
Yeah.
Okay,
You guys good with that?
let's
So
go
what-
back. You go ahead.
I was gonna say like 12:30.
12:30.
Let's take a touch shorter lunch, but that's why we can kind of get back on things. That sort of stuff, okay?
12:30.
Everybody good? 12:30.
We're definitely behind yesterday, but we got done early, so it'll be fine.
I don't know, my power's kicking right. Like, no,
Hey,
it's not.
get some energy.
Don't
Don't get left, but come back. Don't be all rest and digest up. Get some soda in there.
Energy drinks are acceptable. We also sell them.
We're a little sketchy. I think we should stop, personally. We got coordinate through, we should just cut it out.
It makes money off of them.
Well, no, because that fund never seems to go up.
Hey.
Vaccines. Not in my realm. Yeah.
No, I actually put it. I don't know how to watch it.
Do you know something we can do something about? Find a site you have gotten. Absolutely.
Yeah.
I'm so confused, I'm not gonna lie, so.
Don't eat today.
Yeah.
Don't eat today. You're not sure. My biggest fear is we're getting behind.
No, I made her sit down with it. Made her sit down.
Brady's here all day, so.
It's been a whole day. But then-
I tried to, and I'm like, I'm gonna mess it up.
And it was better told now. I want to stay on top of the shit to do at the end. Yeah, I'm here all day. So it's
Okay, yeah, I'm so confused.
I don't know how.
So like my fans, explain it, I mean, I'm lost though, I wasn't here, so.
Did you guys hear who was calling? Well, if you could just come watch one early, I would do it. Just remind me.
I appreciate it.
But yeah, I will figure out if you want it. I'll figure out how to get it down and get it out.
Didn't know you'd stopped recording.
I pause it over lunch so that.
If the AV, so we missed the essay number to it. The AV junction, the AV node kicks in. Do you think we have a P wave?
All is happening?
Do we have a P wave on the EKG? If the AV node is what's firing and the SA node's not firing. There's no P wave, or occasionally we get an upside down P wave, and I'll tell you why, so don't freak out. So here the electricity started at the top. When we see the P wave, we see it go down. Remember we said between the P and the Q is flat when it's in that AV junction. And then we watch it go through the ventricles. Here, the electricity starts in the center, right where that's at, and it goes out in both directions. It goes up through the atrium and down to the ventricles. And so if we see an upside down P wave, we're just seeing the electricity go through the SA node backwards. It started out lower and went through it, through the atrium, upside down. So let me show you what this looks like. If there's no P wave, it just looks like fairly normal beat with a flat line there. Or it looks like a fairly normal beat with a small P wave right before the beat. Small upside down P wave. The electricity goes through there either way. Here we just don't see it, it's blocked out by the QRS. Here we see it fairly, but it's upside down because the electricity is traveling instead of from top to bottom, it's traveling from the inside up. So it's just flipped direction. It doesn't really matter, it's not a big thing. You just have to know this is a junctional beat. Everybody okay with this being a junctional beat? Other canard?
I think so.
Okay. So if the AV junction is firing, it means the SA node is not firing. So for whatever reason, doesn't really matter, this has failed to do its job. What is a normal, if we call it a junctional rhythm, what's the rate?
40 to 60.
Functional is 40 to 60. Okay, so this has not done its job and this system kicked in.
Is there a divot right there? I can't tell.
There's a little upside down P wave, right? Very small. Because normally we don't even see it. 40 to 60 is normal. What if it's greater than 60 but less than 100? Without a P wave.
Accelerated junction.
Accelerated junctional first. 60 to 100. What if it's 101 to 150? Then it's junctional tach. And while I'm going over these rhythms, they don't matter yet. Don't freak out. If you're not getting it yet, it's okay. 101 to 150 is junctional tach. What's the difference between this and this? Because let me just show you what this looks like. That's that. What's the difference between that and that? It's just a P wave. It's still what we would call a narrow QRS. It still has a T wave. There's just no P wave. I know we haven't really gone over all that yet, but put our diagram up here. It's a P wave. The first downward stroke is a Q wave. The first upward stroke is an R wave. The last stroke, the downward stroke, is an S wave. And then there's a T wave. Okay? You don't always have a Q. It's always called the QRS, but you don't always have a Q. What does the P wave represent? Yes, and atrial depolarization. That's correct. The atrium depolarizing. You're seeing the atrium depolarize with the P wave. What do you think the QRS represents?
Hold on, wait. Ask a question.
What does the QRS represent?
So if you.
P wave represents atrial depolarization, atrial firing. What does the QRS represent? Right? Ventricular depolarization. The ventricles fire.
So why does it drop and then shoot?
It doesn't always.
Oh, that's why I said there's not always a case.
It's not always a cue. Sometimes it looks just like, only there's a little bit of it, but not, there doesn't have to be any. It could literally just go something like that.
So could the drop just represent that there is like a slight pause in between, like a firing on or no?
No. We'll talk about what that Q wave represents more as we get farther in.
Sorry.
It's okay. Don't be sorry. Good questions. Okay. These have P waves. P wave, P wave, P wave. Q R S T. There's little Q R S T. No Q R S T. It's confusing. It's okay. So the ventricles, the QRST represents the ventricle depolarizing. What's the T represent? Repolarization of the ventricles. Which begs the question, where does the atrium repolarize?
Right after. Between the T and the T.
Between the S and T.
It repolarizes somewhere in the background and we can't see it behind the ventricles. The ventricles are always going to outweigh anything else. They're bigger, and so we see more electricity. So if they're firing and something else is firing at the same time, we're not going to see it. It's gonna out electricity. It's not probably a good wording. Now, important to note, these are narrow QRSs. They're not real wide and nasty. That's because electricity is coming from the top down. It's either coming from the AV junction above the ventricles down, or it's coming from the SA node above the ventricles down. When we start firing from the ventricles, the electricity starts in the ventricles and goes out in both directions, which means we go from a narrow QRS on the top down stuff to a wider QRS. If you see a wide QRS, it's too wide. We'll talk about measurements later and all that crap. If it gets too wide, it's firing out of the ventricles. The ventricle network is our third system. It's our backup to the backup. Primary, secondary, tertiary. I say the ventricular network because the electricity can fire from anywhere down here. It can fire from the bundle of his, it can fire from the bundle of branches, or the Purkinje fire first. Anywhere down here. Okay, so it's our third system. What do we think it starts off firing at? 20 to 40. What's that called? Called idioventricular. Idioventricular is 20 to 40. If it's greater than 40 but less than 100, what do we think we call it? Using context clues.
Accelerated.
Accelerated idioventricular. And I normally just abbreviate that ACC, idioventricular. What if it's greater than 100? Everybody can get this one if they just think about it. Somebody other than Emily. TAC, what TAC? Just TAC. Ventricular tachycardia, also known as VTAC. Yes. VTAC. So these beats can look funny. They can look like that.
How do you say that first word?
Idioventricular. Or they can look like that. Or they can look like some sort of combination. They look nasty, but they're really wide. Any of these are wide beats, wide QRSs. That's still called a QRS. It's wide and nasty looking. Okay. Do what?
So like, I feel like my picture.
Don't worry. We're going to put up real pictures. You're going to see real, not mixed drawings. We already talked about nerve stimulation, sympathetic versus parasympathetic. We don't have to worry about that. We're gonna run through all of a sudden, we're gonna move through some slides, because some of this is just BS in the background, okay? So we still do our assessments, we still do our ABCDEs. Okay, when we're looking at cardiac concerns, we're looking at different causations. Could be unstable angina, could be non-STEMI, could be a STEMI. What's a non-STEMI? Other than what you get transferred for all the time. A non-STEMI is a heart attack, so and a myocardial infarction. There's tissue damage occurring. So there's elevated troponin. What's troponin? Cardiac enzyme, elevated troponin. The heart gives off troponin when it's under stress. There's elevated troponin occurring. Now, troponin could be due to non-cardiac causes, right? We get a breathing problem, been going on for 2 weeks. Sometimes we get these non-STEMI patients go to the hospital, and I'm like, they've been in respiratory distress at 80% for like 2 weeks, and they haven't been able to manage the respiratory distress well. And then we transfer them out for non-STEMI. That's not cardiac. No. Those are respiratory cause troponin bumps. Okay. We'll take them up to the city, but this is done. Then there's the patient who's having chest pain, who feels bad, looks bad. He could be having a he day, he can be having a non-STEMI, and it doesn't mean that it's not an emergency, it's just less time sensitive. We've been able to give them enough medications to keep the blood flowing. It hurts, the heart's under stress, but the Brilinta or whatever, come on, brain, not the word, it's fine. The blood thinner, whatever we're giving, is getting enough blood through the system. We might be doing a nitro drip in our world. Hospital uses different things. Do it. Heparin, thank you. Yeah, thank you. Heparin, and it's getting enough blood flow that we don't have to urgently take them to cath. But tomorrow morning at 9 o'clock, when the STEMI team's in, they're going to schedule that baby out, get them in there. They probably have a 90% or higher inclusion, maybe 99. But it hasn't caused tissue death yet. We're maybe having some damage, not enough damage for us to see it on a 12 lead. On the other hand, a STEMI is an acute time-sensitive emergency. There's tissue damage and possibly infarction and death going on. And so they need to go to a cath lab urgently. Don't stop and, smell the roses, get them going, okay? We'll talk about what that whole STEMI means. But it's ST segment, this flat spot right here, elevated myocardial infarction. So I'll show you that later. We're not quite there yet. Don't freak out. We know what this looks like, right? We run chest pain calls, dyspnea, fainting, palpitations, and fatigue. Who do we do 12 leads on? Yeah, so any kind of syncope, any kind of near syncope falls with unknown origin. Breathing problems, chest pain, abdominal pain. And then women who don't feel well or feel impending doom for sure. If somebody looks sick, and they say they're going to die, you better take it seriously. If they look like they're super dramatic, you don't have to take it seriously. But you know what I'm talking about. They look gray, they're sweaty, and they say, I think I'm going to die. You can go ahead and reassure them, not today, but you better be prepared for them to die in front of you. We don't lie. But not today is kind of like, not on my watch. I'm not planning on letting you die today. It's a little reassuring and it's a little like, don't you do it, Satan. Like.
I tell them I have 2 rules. No one dies and no one multiplies.
No.
That's crazy.
That's crazy. Neither one of those work out, so.
Yeah. I mean, it never works. But
no, I was going to say, I've been on both ends of that. That don't work out. He's like, I already told you the rules. So, yes, where were we? Sorry. No, you're fine. That's fine. I don't remember what I was saying. What were we talking about?
You're dying, they're dying.
Oh, yeah, take him seriously. Here's another thing. They don't teach this in EMT school. I don't know why the hell not. It's not even in the freaking PowerPoints for medical school. Cardiac seizures are a real thing. What am I talking about? Has anybody seen a cardiac seizure? It's right before they die. Right, like, it's normally oxygen starvation of the heart and everything, right? And so they're probably going to be fib. But they'll do that final, and then they'll just be dead. So if you see a patient kind of go, you better check pulse. If they've been going down the chest pain route and then they do that, you better check pulse. That's called a cardiac seizure, and they just died in front of you. So Super sweet.
How does it cause seizure?
I'm assuming lack of oxygen, not just to the heart, but also the brain.
Oh, so it's like the same things happening at the same time.
Horrible timing.
That's how.
Yeah. But I don't know that, don't quote me on that. I don't know the causation. I know that's a real thing and I've seen it multiple times. Yeah, it's a real thing. All right, palpitations. I need you to know palpitations does not equal pain. Somebody says it feels like what is palpitation? It feels like my heart is beating out my chest. It feels funny, it's uncomfortable. Don't take that as pain. Okay? Uncomfortable is not pain. Pain is pain. Okay? So ACLS has dumbed a lot of stuff down, starting in 2020. We're still dealing with it today. So they said any pain gets X and this happens and you go that route on treatments. Palpitations is not pain. So if it feels funny, it feels like it's beating on my chest, slow down, we're gonna treat that a little differently. We might have them blow through a straw, we might give them some adenosine. Okay. We're not gonna just light them up. I need also for you to know the word shock is a bad word in this classroom. You will catch me saying it sometimes. Try to correct me politely. We don't say shock. Shock means too many different things. Did you defibrillate them? That's a real thing. We defibrillate the dead. Okay? Defibrillate the dead. Did you cardiovert them down because their heart rate was 220? We cardiovert them. Or we pace them up. Pace people up, we defibrillate the dead, some of them, and we cardiovert them down. But we don't shock anybody because I don't know what the hell that means. So if you say shock in a scenario, we're going to say, no, sorry, I don't know what that means. We'll probably give you a chance to correct yourself, but we're not that big of jerks. But shock means nothing to me. And you'll catch me saying it sometimes too.
Old habits die hard.
Yeah, exactly. Don't say shock. It's not a good word for us. We don't know what it means. Especially when we're trying to judge if you know what the hell you're doing. You're like, I'm not shocked. Cool. I don't know what that means. And they're like, okay, how many joules or milliamps are you using? Because I don't know. You probably did.
Nope.
You bring it up?
Yeah, I did. I always do.
The word's trash, dude.
Is
You're
it?
really getting an upgrade from somebody.
I should.
Dang it.
Hey, he unfroze everything. I just saw that over
Did he
lunch.
really?
Yeah.
Everything?
Yeah.
He unfroze everything.
I think so.
He's,
Today was the day that Fed rates were changing and everything. All kinds of stuff.
I don't know if it's going to track me or not. I think he's just really good at scaring people. And then everybody's like, ah, and then he's like, ah.
It's not tracking you at all.
I gave up on it. You get to the little point where yeah, if they feel like they're gonna die, they're gonna die. That's the facts. We're still gonna get their med history. What meds do you need to know as paramedics? Not only every drug we carry.
What drugs they could be taking?
Everybody. Oh, copy. Quick. Thank you. No. So, like, but people take thousands of them. There's thousands of home meds. Do I expect you to know thousands of home meds? No. So, what drugs do you need to know? What types of drugs do you need to know?
Blockers,
Heart.
thinners.
Bleeding control.
Heart, blood thinners, those are the big ones. I'm not saying that's all you need to know. Andrew's gonna make sure you know other drugs that are home meds. But the biggest drugs you need to know are blood thinners and heart medications. Because when that person's unresponsive, I don't know what's going on with them. I was bad at home meds. Like, one of the reasons why we try to do more of that with our classes so that you guys are better at it. But you've got to know your blood thinners. So what are some blood? Xarelto. What's the other name? What's the other name for Xarelto? This slide makes me so mad. I had a call like now 3 or 4 months ago. And I checked the list and I was like, no, we're good. And then I get to the hospital and they're like, oh, he's on thinner. I'm like, no, he's not. I looked at the list. They're like, yeah, ribofloxacin. Right. Sounds a little bit like that.
Yeah.
What is it?
It's riboflavin or flavin. Yeah. It
It's
looks.
the other name for Xarelto. And I was like, no. Now what? We got that. My stupid self. I was so mad. Oh, so mad. But what are some other ones? Xarelto's one. Coumadin. What's another name for Coumadin? Warfarin. What else? Plavix.
Any studies?
Eliquis. These are our blood thinners. We do have to commit them to memory.
Is aspirin a blood thinner?
Do it.
Is aspirin a blood thinner?
Trauma considerations.
No. Yeah, not in trauma considerations. Aspirin is not a blood thinner. Some people say, when you ask, are you on a blood thinner? They'll say aspirin. And you're
Aspirin.
like, cool, file that away as not a blood thinner and just move on.
Okay.
It is a blood slicker.
Less thinner.
Don't,
Well, alcohol, I would say how much, quantity, right? So I had a glass last night, I don't care. I have a glass a day, I don't really care.
Alcohol.
I just drink half a bottle.
Mechanism.
what is it? Alcohol
Alcohol
compound.
plus mechanism.
Plus
So, like,
mechanism with you.
alcohol with any MVC, alcohol fall down, not a trauma. Fall down thinner is trauma.
Exactly.
Hey, and that does actually bring up kind of a good thing. For your guys' whatever your guys' local hospital is, knowing what their trauma criteria is doesn't necessarily mean a whole lot to us, but knowing what they're gonna potentially do may help you do what's better for the patient in the long run.
Absolutely, like, we should know when to activate.
Sure.
You might be like, that's not my job to heat them up. Whoa, stop, what are we here for? Are we here for us or them? No, we're here for the patient. What is gonna get Mr. and Mrs. Smith the best care possible? Guess what? I've been to the meetings. The best care possible for Mr. and Mrs. Smith at any hospital is when we early activate for them. For strokes, STEMIs, and trauma, when we own the early activation, the hospitals do so much better. Their times are better. Everything's better when they get an early activation. The opposite side of that patient POVs and walks in. We just slowed the whole response by 15 minutes. And it makes perfect sense, right? We call ahead, we give them an alert, they're starting internal processes. Labs coming down, X-ray, whoever they need. Yeah, they're getting somebody out of the way that might be sitting in a bit like, it said, so you might be like, but this isn't a trauma for Nick, because I'm going to a level 3 trauma center, it's not we don't count that as a trauma. Rollover, no mechanism, that's the only thing, patient's doing okay, is a simple rollover trauma alert for y'all.
Yes, yes.
That would not trigger a trauma alert for Jacob, because we run rollovers with basically no injuries all the time. And we're bad about activating that, aren't we? Yeah, just be honest. We suck at activating that, because it's not a trauma in our minds. Rollovers with no injuries, that's like every day. What it is for the hospital, because they have to start their internal mechanisms to make sure that person's not actually broke. So if we say, hey, level 3 trauma activation, our level 3 doesn't match theirs. I've asked them to go to Alpha and Bravo or whatever, but it hasn't happened, it's fine. We all run different worlds. So we just say level 3 trauma activation, and they can figure out what they want to do. But we should activate, and I'm saying that. Your hospital, whoever your hospital is, activate it as a very low level acuity trauma. And then they can decide what they want to do with it. But you're starting the process.
So when you call it in, you're supposed to classify it as trauma, or is it trauma where it might look the hospital?
So technically, state law, level 1, 2, and 3 traumas, based on the trauma center.
Both of them are the same.
So it doesn't matter. So if you're going to level 2 traumas, you don't have to say what it is if you're going to that level trauma center. If I'm going to Western, I'm saying level 3 trauma for the knowledge of them like this bullshit. Now, if I bring them a level 1 trauma, they're going to know because the pitch of my voice and because the vital signs. I don't bring level 1 traumas to a level 3 trauma center unless and generally I still won't, because I'll just add more help on my ambulance. I will take as many people as I need and ground 3 buses if I have. But if we need blood, if we need certain things, if they're coding, we're going to the local trauma center. To our level 3. So no, I don't, you're right, to your point, if I'm going to research, I don't normally say what level it is, I don't care. When I'm going with something that is more BS, I communicate that, but you can't say BS over the radio, so I said it's level 2 trauma.
And this while we're talking about traumas, STEMIs are going to be kind of the same sort of thing. So there's going to be certain criteria that we talk about. I don't want to get too far ahead. So
We talked about non-STEMIs at the same time.
okay, so there are going to be certain criteria that meet a STEMI criteria or it doesn't meet a STEMI criteria. However, what could happen is you could get to the person before the STEMI shows up. They're still having heart damage. It's just not showing up on your EKG yet. So what we sometimes will end up doing in those situations is, hey, I'm coming to you as a STEMI center. I have X, Y, and Z. However, I do not have the STEMI criteria, but it's still putting everybody on alert. Oh,
so it
shit.
always makes me nervous when another instructor comes in and talks, because I'm like, I don't know what he's going to say. No offense, I trust Andrew inherently. But I was like, is he going to say what I want to say? You said it first.
I was like with the shit one.
Good job.
That wasn't even. Hey, was that?
But he's having a heart attack. or he's about, we caught him early. I ran a guy just the other week, I wasn't even on, some family called me, some friends called me, and they're like, hey, our dad, blah, 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 I'm like 2 blocks away. Here's the bus turning, and I pull in to check on him. And he's gray as shit, he's had previous heart attacks, he's diaphoretic, like textbook. He looks like he should be on the slide, having a heart attack, right? Put him on there, totally fine. I'm like, we are really early, when to start, like 5 minutes ago. You've already taken nitro? Makes sense, keep going with the nitro, keep doing all the stuff. Take him to the hospital, never spikes a steady. They hold him for 2 days before they actually, troponins are in the hundreds, like stupid high. Pisses me off. Anyway, then 2 days later, they finally do the cap. And guess what? He's got 100% gluten. Like, he was getting enough blood flow with all the meds we dumped on him, all the nitro the whole way to the hospital, and all why can't I think of that? What is it? Heparin. Thank you. And that's what, but Andrew's right. That's not somebody I'd take to Western. No offense, they're not STEMI center. I'm gonna go to an interventional STEMI center. And then I'm just not gonna, what I won't say, this is where I was nervous, because some medics, there is a population that just activate. Just activate. Just activate. They'll deal with it. No, that's bad. That's bad. They stop trusting us really quick. You'll get doctors that'll come down. If I had a doctor come down for cardiology from Lee Center, I'm gonna get you. This is what he'd say. When in doubt, activate, it's fine, we're here, it'll be okay, our cardiologist take a look, it's all this kumbaya bullshit. Then you do it. What happens? We got an ER doc, they stopped trusting us. That happened for a while, they'd stop going after our activations because we overactivated so much. 2, you got an ER doc giving you all kinds of shit, because you don't know what the hell you're doing. You'll look dumb. No, it's only a STEMI if it meets criteria, and we're gonna go over that. STEMI criteria is actually pretty narrow. Strokes? Fucking everything's a stroke. I don't know. Everything's a stroke until proven otherwise. Altered mental status, blurred vision, anything that even seems like it might be a stroke, activate a stroke. As long as the sugar's good, activate a stroke. Right? Am I wrong? And then they stick them in the CT, they spin it up. Here's the difference. CT's non-invasive, right? It actually doesn't even cost that much. CTs are relatively cheap these days.
I mean, they break, but like.
Yeah, not the machines. Not the machines, but the picture that they print out, it's not that expensive. On the opposite side, going to the cath lab is an invasive procedure. There's an inherent risk of dying. And they make you sign a waiver if you're awake that says you could die. So that's the difference. One is everybody gets a CT, no big deal. The other is it has to meet this really narrow criteria. And we're going to go over that in the next 4 weeks.
We had a lady that picked her up and she thought we did 12 lead and we're like, ours doesn't look like she is anything, but we called it into St. Joe as a STEMI. We get there, cardiologist looks at it too, and he goes, after David, I don't know either. Because we're gonna send her up to the cath lab. We get a phone call an hour later, so they took her to the cath lab. She coded on the table and they brought her back. We activated as a STEMI, and when we got there, we were like, kind of feel stupid for doing it because we had stuff, but we did. She was showing the signs of the monitor was there. And turns out she actually did.
Pull the chest off, it still stays.
Yeah, I would not activate it if it's not a STEMI, but I would absolutely go to the correct facility. I would absolutely top it up, like, that radio report, that this patient looks like they're having a STEMI, however, we don't have the criteria yet. I wouldn't, but we are coming to your cardiac center for this reason.
There's some keywords you can throw in there. They've had a previous history. She says it feels just like the ones before. 10 out of 10.
Passion,
Yeah, I mean,
crushing chest pressure.
give it
Tell
to
a
them.
story. Yeah. Sometimes the same when you call for orders. We're getting off on a lot of tangents here, but when you call for orders, if you call for orders and you give a shit story, guess what? You get shit orders. You give a good story, you're gonna get good orders, even if they don't know you. You call research, they don't want to give anybody anything. They tell good enough story, they'll be like, yeah, have your cake and eat it too, man. I don't care. Start at the center. All right, well, we're doing our assessment. Good thing we don't have this one broadcast. We're looking for surgical scars. What's a zipper scar mean? It had a cabbage. What's cabbage? CABG, not the other cabbage.
Coronary artery blockage.
Bypass graft.
Oh, I wanted to say bifurcation for some.
Coronary artery bypass graft. Zipper scar. Sometimes they code with that staple still in. That's not good. I don't like that. So if they have a cabbage, they have those staples still in, and you're doing CPR, how do you do that? Alright.
Hey, it's a good shot. Jesus Christ.
That was not a bad idea. It'll bleed, it'll cut you, you'll bleed. Extrication gloves with gloves inside. That works if you're not in a hospital setting. You're not really supposed to do CPR with the staples in, but what are you gonna do, man? They're dead. You gotta do something. Looking for pacemakers. Some of our pacemakers aren't gonna show up on our monitors, so you have to physically feel the patient. A lot of times they're over here, occasionally they're over here, most of the time they're over here. Oh, listen. Well, I'm not gonna tell you I listen to heart sounds every day because I don't. And I like to train you how I fight, so I'm not good about heart sounds. I listen to heart sounds and cardiac arrest to see if they're dead. When doctors are digging for femoral arteries and everybody else is up here, I listen to heart sounds. And if the heart isn't going lub dub, they're dead. I don't have to call for a Doppler stat. I don't have a Doppler on my ambulance. I don't have to call for ultrasound stat. I'm not doing any of that shit because let's go do the same thing. If you hear no noise, they're dead. If you hear noise, they ain't dead. It's crazy. Lub dub only happens if the heart's doing the things it's supposed to do. Did it work? They were dead, right?
They were.
Yeah. You didn't have to get the Doppler?
You wouldn't have Doppler. I'm just.
Any chance you could relay that? to
No.
them now?
No, I did not.
I wish I could relate it to the whole world. You don't.
They have a big fucking heart on for the ultrasound. And it's-
After you and I talked about this, I talked about it with him.
And here's the thing, there is a time and place for ultrasound. I'm not sure how much of it's in the ambulance. And I'm not trying to be old negative, like, great, I can get an IV that I can't get, but I also have an IO if I need that. So I can get an IO. A fast exam in the ambulance for abdominal trauma, I struggle with that, go to the hospital. The only time I could see doing it is that patient that's trying to refuse. And then I'm like, let me just look at your bill. And I'm gonna talk you into it. But that is so seldom. And then the chances that the guy that wants to refuse actually needs to go to the hospital, and then you're gonna find something on a fast exam is pretty low. They do cool shit. I'm not saying they don't. Ultrasound in the baby would be cool, but I'm not gonna sit on seeing do it. I'm gonna go to the hospital because I don't like nobody's supposed to be having babies in my ambulance. So I think for the future of EMS and maybe that community paramedic role or a battalion chief vehicle where we're dealing with a problem, we're trying to convince somebody, maybe mom's trying to refuse or mom wants to know if she needs to go to the hospital. Obviously we're gonna encourage her to go to the hospital, but we can check on baby and baby's lub dubbing like they're supposed to and it's all good. Cool. I don't think we're gonna use a pre-hospital to find an IV because if we can't get an IV,
Yeah, we can use it.
we're gonna get an IO. And if we can't get an IV or an IO, we ain't gonna sit on C trying to do that. We gotta get to the hospital. I don't know, I struggle. I'm not against it. I sound like I'm against it. I'm worried crews are gonna slow down. We run 20-minute on scene times now, which I think is a little long, sometimes 21, sometimes 22. Our average is right around 20. I don't think we need to be there that long. My scene times aren't that long, 99% of the time. I mean, trust me, we all have the outliers where, we can't make a decision to save our life or, we're up 18 flights of stairs and we need a helicopter to get out of the situation. But, man, I don't know. All right. Are you ready to All right, let's talk about some of these terminologies. Pulse deficit. The apical pulse versus the peripheral pulse are different. What does that mean? What does that mean?
I don't know.
What is apical pulse, guys? We know what peripheral pulse is, right? Far out? What does apical mean? Closer to the cord? So we have a difference in those. That could be a problem.
Would an apical be like your carotid?
I would go with your carotid.
First, the heartbeat as it is spelled at the bottom of the heart.
Bottom of the heart. I don't know when to do
Typically
that.
located on the left side of the chest between the fifth and sixth intercostal space.
I'm not feeling for a pulse there.
Yeah. Okay, blood pressure, you get pulsus paradoxus.
Check.
What's pulsus paradoxus? Because these terms right here, as stupid as they are, they use these on registry too. I know it sounds like everything's on registry.
There's systolic one.
Normal during inhalation.
Yeah, so it drops more than 10 points during inhalation or inspiration. And then pulsus alternans is a beat to beat difference in the strength of the pulse, like it's strong, weak, that kind of stuff. And that can be a sign of like cardiac tamponade. We know what normal blood pressure is. You know, a lot of times we think of hypertension as like really high, but technically it's only 140/90, either greater than 140 systolic or greater than 90 diastolic. We don't often look at that because we see a lot worse. So when somebody's like, "Oh, I have hypertension," they're like 140/90, I'm like, "Nah." But honestly, that's the start of the larger problem or the ongoing. Here's the question: are they 140/92 with beta blockers? Because they do have a larger problem at that point. They're not well controlled and they're on meds. Things to think about. Yeah. Some of that stuff is just done. Well, we didn't talk about that. Go back one. If we get widened pulse pressures, meaning the distance between our systolic and our diastolic are spreading out, we're in late stages of shock. If we get narrow pulse pressures, we're in tachycardia or tamponade. So if we were at 120/80, and now we're at 130/110, we could be getting into that tachycardia or tamponade. Heart tones. I'm going to blow through heart tones fairly quickly because I don't listen to these very often. It's a good time for Tyreek to go to bed. S1 is your normal love sound. The normal sound that you hear. Okay? S2 is your normal sound. It's your normal dub sound. S3 would be an abnormal sound, and you would hear this like vibrating noise. S4 is heard right before S1, and it could be due to a stiff ventricle and hypertrophy. So it's mostly we're dealing with valve issues when we start hearing extra noises. Valve issues could be like this.
The mitral valve is one of the 4 heart valves. It controls proper blood flow from the left atrium
Yeah, just like that.
to the left ventricle. In mitral valve prolapse, the valve bulges inward, does not close properly, and may cause blood to leak back into the atrium. This condition is called mitral valve regurgitation.
Or you can get this.
Oxygenated blood is pumped out of the left ventricle through the aortic valve and into the aorta. If the leaflets of the aortic valve calcify and do not open fully, normal blood flow out of the heart is obstructed and decreases. This is known as aortic stenosis.
Is that the
big
how
pros.
simulate stuff? No?
And then when we talk about tamponade, this is what tamponade looks like.
A healthy heart can expand and
Visible body.
contract freely within the pericardium, but when the pericardial cavity fills with fluid from trauma or infection, cardiac tamponade can occur. As fluid accumulates, it presses inward on the heart and prevents the chambers from dilating fully. Less blood fills the heart and contractions weaken, resulting in reduced stroke volume. The more fluid builds up, the more cardiac output falls, and the patient experiences hypotension. Meanwhile, blood backs up into the vena cava, causing elevated venous pressure and a bulging jugular vein. The pericardial fluid also muffles heart sounds. Acute cardiac tamponade can lead to cardiogenic shock and death if left untreated.
The more I learn, dude, the more I'm like, I don't know anything.
Jesus Christ. All right, if you need a quick bathroom break, now's the time because we're about ready to get real. Not like the app.
So we're getting to that. We've never had it.
What are your worries?
So we said we're over.
Who's your chief brother? Sperry. Sperry? Yeah.
We just got a new medical rep.
Yeah.
We gotta wait for Dr. Gus.
He's trying to retire.
Yeah, I think it's Simmons, I think is the new one.
Yeah.
Drawing is just.
No. The Zolvent is the way to go.
I think that's what we're saying.
Okay. If you need, I do a pretty good class.
Well, we actually have a guy that as soon as we hear the address, we're like, boom, he's getting CPAP, emergency CPAP as soon as we get in there. Last week we ran him. It was on the 15th, we ran him. he was trapped under his mattress all night for about 8 hours, screaming all night. And the neighbors were like, oh, he just was maybe had an episode or something. Well, then they finally called the next day. We go in there and he's trapped under his mattress. And I mean, he's like struggling to breathe. Get him out there, load him, get him to the hospital. 4 days later, they said he was dead.
Oh, wow.
Like, fractions all around.
And you're in a callus rip on while you were down.
You should never know. If you call this working out.
Shut up, you're such a. No, I haven't.
Who boxes?
Thank you.
You know who the artist is out of the instructors?
Yeah, it's not me.
Did you draw this?
Also, since we're here, I need to tell the story of Andrew. I got so mad because I don't do well with altercation with middle-aged women.
Okay, yeah.
What is the rate for a non-rebreather? What is the leaders? What are we allowed?
Oh.
Go ahead.
This is still bothering you.
Just curious.
It does, it does. 'Cause I see her often and she looks at me like I'm a dumbass every time I
Like 10 to 15 is probably.
There you go. That's all that matters, right? 10 to 15. 10 to 15, not just 15.
Correct.
I take a patient in.
Used to be the standard.
Who is having a COPD
I've
exacerbation.
also seen people who, like do it up to 25, but at some point I feel like that's just like
Great.
not necessary. But
Yeah,
But I had a patient with 10 liters, you know, take him to the ER, send him to East, the fucking best place for mean ladies to be at.
got it.
And so I take him in, and there's like, for some reason, she had like 4 other nurses in there helping us take over this patient, mind you. They could just get in bed by themselves. But anyway, so immediately she sees that they're on 10 liters for us. Remind you again, they were at like 75. I put them on 10. They got up to 95. We're big boom. You know what I'm saying? You're good.
As we do.
As we do.
Right.
The lady immediately was like, you do know, non-rebreather is 15 liters per minute. I was like, oh, because I couldn't argue because I'm a pussy. So I just took that, and then the other nurses in the room were just staring at me like I'm such a fucking dumbass. And then she closes the curtain on me. Like
It's just like slides it.
yeah, she really did that. She truly did that. She closed the curtain on me, and so I'm standing there like this on my eye.
I wouldn't never. I wouldn't never.
I'm standing there.
I know how to be super respectful. I'll be like,
Oh, that's so interesting. You know what? I think you were right. But you know, I looked that up and it's actually 10 to 15.
I
liters
did
per
it.
minute
I did
in
it right
non-rebreather.
there. I did it right there on my phone too, just to make
I
sure
would
I was
so-
right, but I
I'd be
didn't
like-
show her because again I didn't want to argue. Because I didn't want her to be like, oh, you were right about that. I did find something else.
But it does say 1990 when the curriculum came out that it was, you're right, it was 15 then.
That's not even the worst part though. So she closed that curtain on me. She closed the curtain on me, and I just saw the iPad with the curtain like this close to my face, and I was like, oh. And so my partner, his name was Jack. Jack's looking at me. He's like, what? I was like, oh no. And then she like opens the curtain hella aggressively. She's like, are you gonna give me a report? And I was like, you just locked me out of the room. You just closed me
Is
out.
this because you're wearing a John Arm shirt?
No, actually, I don't wear one. I wear one that just says ENT. I truly think it's because she smelled that I was a bitch. And it just- She smelled it. She smelled it on me.
Smelled the fear.
Smelled the fear on me. The whole time I was thinking, I was like, I'm feeling like classmates today, right? You really
I walked out.
Oh man.
You can't be thinking that stuff.
If it was a guy, I don't feel anything.
You gotta
taken aback.
respectfully tell them they're wrong.
It's silent all the way back to the station.
I sat there. I was
Were you just looking out the window? They could have like taken that black and white photo.
They truly could have. I was just looking out the window, just like drinking the background, crossing the roads.
Alright, Andrew's handing out this graph that's on the board. It's folded over so you don't freak out. So if you can manage yourself, you can look at the whole thing, but if you're gonna freak out, just even fold it over, it'll be fine. We're not going to the other side today anyway, so it doesn't matter.
We're really only doing like
The left side. Yeah, not even all that, just a little bit. Okay, we talked about this a little bit. We're not ready yet. Don't be writing anything yet. Okay, what do you think?
I said I needed to get that, so glasses already, I have an appointment coming up.
Yes. We already talked about this, depolarization. That's what's happening when we see each one of those. We're gonna call them strokes on the EKG. Something's depolarizing. The P wave represents what depolarizing? This is the interactive portion. I will long pause until somebody answers me. So the P wave represents what depolarizing? Atrium depolarizing. The QRS represents what depolarizing? The ventricles depolarizing. The T wave represents what repolarizing?
Ventricle.
The ventricles. Where does the atrium repolarize at?
Somewhere between the Q and the.
Yeah,
Q and the
QRS.
yeah.
Yeah, perfect. So these are some busy slides I really hate. They're terrible. Okay, that's better. Some slides just suck, guys. It's just, and this one has a lot of words on it. Here's the bad thing about this. The picture's actually quite good. So we're looking at the ventricles, and we're looking at the ventricle depolarizing. And you have to know these phases, and I think it's very imperative because it applies 0 to what you're going to do in line. But for the test, they ask questions about the phases of the cardiac action potential cell depolarization. You really need to know phase 0, cell depolarizes, and phase 4 is the resting phase. If you know phase 0 is the cell depolarizing, and phase 4 is the resting phase, you can basically figure out 1, 2, and 3. So phase 0, the cell depolarizes. If the option then is the cell begins to repolarize, that's definitely going to be right after the cell depolarizes, right? So phase 0, cell depolarizes. Phase 1, the cell begins to repolarize. Phase 2, sodium and calcium enter the cell, and calcium follows out. Phase 3 is the final phase of repolarization. That makes sense. And then phase 4 is the resting phase. You know 0 and 4, and you have to line this up. For example, if it put all these here, the made phases without the numbers, and said order these from whatever to whatever, you had to drag and drop and move it in place. You could do it as long as you know phase 0, cell depolarized begins to contract. Phase 4 is the resting phase. You can figure that out. Okay. This is kind of helpful. When the QRS hits, the top of the R is the end of the depolarization. It's the end of the fire. After that, we're slowly starting the repolarization process. Okay. From the top of the R to the first bit of the T, this section right in here, the cell cannot beat again. The ventricles cannot fire again. If they have an internal firing or an external stimuli, at the wrong time, the wrong millisecond there, they go into V-fit. Tamar Hamlin got hit with a helmet at the wrong millisecond. Right there. Right here. That's where he got hit. And then his heart started quivering. And he went down. And the EMTs on the field was stared at him for 5 minutes, 3 minutes probably. Before they're like, somebody should probably put him on AED. That was after the athletic trainers stared at him. Everybody just stared at him straight. It wrecks me to watch it. Mm-hmm. I just like do something, like, you know.
And then he was exposed on Sunday. Did not play well.
He did
not play well.
So that's the absolute refractory period. From the top of the R to the first part of the T. You cannot have another beat. If you do, you're going to go into cardiac arrest. Okay? The beginning of the T to the end of the T, you can have another beat. You can have another QRS happen. It's just not going to be as strong. That's called the relative refractory period. You can have another beat, but it's not going to be near as strong as normal. We already talked about that SA node. It's firing, how it's the dominant pacemaker. Doctors are going to make up some bullshit terms to, when they don't know what's going on with the patient, to say like 6 sinus syndrome. We'll talk about those in a second. The AV node is the backup to the SA node. Once again, it holds that energy just for a half brief millisecond to let the atrium fully squeeze before the ventricles kick. And then the impulses go down into the ventricles. We're not talking about that today. We already talked about sympathetic, parasympathetic nervous systems pretty thoroughly, I feel like. Brain sends signals. Electrical impulse travel down the vagus nerve to the SA node, stimulates release the acetylcholine. We kind of talked about that. Oh, we didn't talk about these yet. Baroreceptors. What are baroreceptors?
Sensors composed of specialized nerve tissue.
Yes, they are pressure sensors. So as I'm up here teaching and talking, my body is monitoring. I stand up quickly, my pressure baroreceptors are monitoring what's going on. And they might be like, oh, Nick's a little lightheaded, let's speed up that heart rate a little bit to fix the blood pressure. So the baroreceptors report information on pressure to the brain analyzes it, the brain sends us out either a chemical or a neurotransmitter and says, let's do this. Yes. We are assessing the body's response, yeah. That's true. We also have chemoreceptors. Our chemoreceptors are monitoring chemical concentrations in the blood, specifically pH, oxygen, and carbon dioxide. So in the normal human patient, the normal person without COPD, what does our body use to regulate us breathing? Oxygen or carbon dioxide? Okay, carbon dioxide. And then in your COPD, what's it use? Oxygen. It's called the hypoxic drive, and it does that because the body gets used to large amounts of CO2 in COPD, so it can no longer use that drive, so it uses the hypoxic drive, so it waits for the oxygen to drop low, and then it starts to breathe more. And this is why ever since EMT school, we've all been afraid to give a COPD or too much oxygen, right? But in reality, in our time, our relatively short time frame in the ambulances, our duonabs and our treatments are not going to be the problem. The problem is when they're in ICU, and they're running an FiO2, hopefully not at 100%. Hopefully they've weaned them down quite a bit. That's when we can run into issues. Our goal is always not to get them to 100%, but 94 to 99. We're only trying to get, and really with the COPD, or it might even be lower than 94%, might be the low 90s. Okay. Treat the patient, not the monitor. Sometimes the monitor looks funky. You know the number one time I find the monitor looks funky? Lazy EMTs. When they put those 4-lead wires on here, here, and here, you guys ever do that where you go through the shirt? Here's why I hate it. It shrinks the image. When you put the 12-lead on, you leave those 4 leads here, here, and here. I'm not talking about here. This is fine. Here and here. It shrinks the picture and you get false STEMI activations. And the first time it happens to you, you're going to want to shank your EMT partner if they put those on, I promise. Because you'll be all worked up. You'll be like, man, this patient looks fine. Like, they're not acting weird. But that's STEMI. You'll be at like step 5 and you'll be like, hold on a sec. Oh, damn it. And you'll realize that somebody did this to get the limb leads on, and limb leads don't go here. I'm not even that particular, but they don't go here. Okay? And you'll get a false STEMI. So limb leads need to at least be out here. You can do wrists and ankles. I'm not a huge wrists and ankles guy because we work on ambulances that do this. Bounce down roads. So I'm fine with arms and abs or arms and thighs. Wrists and ankles get a lot of movement in the back of an ambulance. Hospital, they're going to want wrists and ankles. They're in a semi-controlled setting. The patient should not move that much. Semi. Stop moving. But
Just say, please don't take your electrodes off.
Right.
Please don't take off your stickers. Saves me so much time.
So this is called a 3-lead. Okay? It's not number of wires. Yes, there are 4 wires. You're right. It's 3 pictures. The 3-lead. I've never done that, so I try not to get hung up on it. Okay? That's proper placement. It's not right above the collarbone on either side. It's arms and abs. That's fine. Okay? For the 3-lead, that's for continual monitoring. So we'll get to that in a second. You can, with just the 3-lead, you can get 6 pictures if you want. You can do what's called a quick 6. A lot of people don't know this. You get your 1, 2, and 3, and you can also get your AVR, AVL, and AVF. All those augmented leads they're taking the 2 poles and they're shooting the gap. So if you press and hold on the Zols, if you press and hold, it will print you a quick 6. Do you know how to do it on a life hack? On any monitor, do what? Should be pressing and hold on the record button.
Just push the
On any monitor, if you go press the 12-lead button without all the 12 wires, you can go through it and print the quick 6. But at that point, why not just do a 12-lead? I don't know.
So we don't even do like the 3-lead anymore. If you're putting them on any lead, it's 12. You're doing 12.
So somebody asked that yesterday because we were talking. They're like, "Why would you ever do a 12 lead when you're doing a 3-lead, or where would you not?" Right? And I'll tell you here, Jake Ed, and this is not like the same, you don't have to do it, I'm just telling you how we do it here. That we put almost every patient on a 3 lead. Like if you're getting your vitals, we're probably throwing a 3 lead. You don't need a 12 lead. You really don't need the 3 lead. We're doing it because that's just kind of our standard of care. We're throwing everybody on 3 lead. Yeah, basically.
So what's different with us big time is the medic PLS law.
Alright, and we don't do that.
They put them on the 3 lead, it's their patient now.
We don't do BLS calls, 911 calls. And there are positive and negative support systems. RNTs are weaker. RNTs are weaker because they don't run the calls. The positive side is there's never a patient that should have been ALS that wasn't. And we ran into. You want to know why we went on ALS like 7 years ago?
Because that was happening.
Too many times. Too many times, too much work trying to figure it out. And I'll be honest, like I know it happens occasionally in PCAD. People should be ALS and not. From a liability management standpoint, it makes no sense. Higher level providers in the same truck. Now, site transfers, you can sell them on pretty easily. Anywho,
Don't even need to sell you.
so at JCAT, if you're riding here when you get to that point and you see us throwing 3 leads on everybody, don't freak out. Medics take the call either way. It's 911 transport. It also helps their transport percentages because when you know you're nobody's like keep on around on getting a refusal. Everybody's going to the hospital. That's just the nice. Anyway, whatever. Okay. So, but if they need it, if they need the 3 lead, they need it. Just doing it for fun, that's different. Einthoven's theory, I don't really like this. I mean, it's fine. Heart contracts, electrical energy is emitted. That theory's fine. But National Registry Platinum are asking now, like, which way is lead 1 running? I don't know how to tell you this. You just gotta kind of like, you're gonna have to study that at some point before your test. Platinum probably is gonna ask you a question of, which way does lead 1 run? Well, it's right arm to left arm, but like, I don't know why it matters to us, which way, you know, like.
Bless you.
It doesn't matter in the field. It's
Well,
Go ahead. You
Has he been here this whole time?
No, I just walked in.
it kind of does. So if we go back.
We're on
to-
day 1.
I know. but
Hour 4.
I know, I'm gonna help them. Nicholas? So, Einthoven's triangle. Think of it instead of like lead 1 runs from this direction to this direction. And you look at it as it's running left to right, right to left, that's fine. But together it's creating a camera that's looking down. And lead 2 is creating a camera that's looking from right to left. And lead 3 is creating a camera that's looking from left to right. So these 12 leads, how this works, it's like we're in this room. This room is like our heart. And each corner of the room is a triangle, is a camera. And each camera takes a different picture of where we're standing at in this room. Okay, that's what Einthoven's triangle is trying to do. That it's just different perspectives of where the camera is taking a picture of the same image. That's why the images look different whenever you look at different leads, just because of where the camera angle is at. You look different if you get a picture taken of your face versus your back. They're just camera pictures. There you go. I'm
gonna use that.
Be good.
I'll use that, but not on today.
You
Because I know what you're saying about like lead. That makes sense. I like the way you said that. I'll come back to that in 12 leads.
Hold on, he needs something.
I'm picking up the daughter, and then I'm probably
Moving.
moving. Unless you need anything.
I'd like to know where those pictures are that keep falling off the wall other than that one. Those are gonna bring your name up, but I don't know where they are.
I don't either.
Okay, good job.
Vamoose.
The augmented just shoots the difference. So instead of shooting the picture straight there at the side, it kind of shoots the middle of 2 pictures. It augments the lead. It's not the end of the world. Don't worry about it. We're gonna talk about that. I will tell you some of the.
Time out. You keep looking at me with a confused face. Do you understand what Jared's talking about? Okay.
I wouldn't.
So-
That's not what I said.
Okay.
I'll be honest.
We're gonna come back to it. Don't worry about it. That's why, like, I don't.
I just feel like saying, forget the Einthoven's theory thing, dude. Forget the triangle and just stare at me for a second. Where you put the leads takes a specific picture of your heart. And that's why all of the leads, you've got your QRS that goes up, down. On this one, it's this big. On this one, it's this big. It's the same heart. it's looking at your heart at a different angle. That's why when you put your 12 lead on, you're taking a closer picture of a more specific point of your heart to see what's going on in the totality of your heart. That's all your leads are doing. Forget the triangle for a second.
That makes sense.
The wires are just wires. Each lead is a picture from a different angle. So when we talk about these wires, now in our ambulances, they're labeled RA, LA, right? LL, RL. The hospital, I don't understand it. They're not labeled, are they? Some of them still, or they still are.
So
Your tele leads aren't.
you have
Tell you this.
right arm, right leg on the 12 lead or on the monitors.
The monitors like
The
that.
monitors
Continuous
are
monitoring.
color coded.
They're just color coded. So that's what I'm saying. You don't have the letters. So it's white on right. You got to memorize this because I didn't tell you the first time you look. White on right. So white skies, green grass, black smoke on left over red fire. That's how I remember it. White on right over green grass, white skies over green grass, black smoke over red fire.
What I was thinking about?
So that's similar to how I've taught EMT students, like putting them on. But honestly, one of the ways that like really made it stick was you have to be very careful with how you're gonna say this, because if you rhyme white and right to a sentence, create a sentence, you're real racist, but you won't forget it.
However, if you rhyme black and left in a sentence, you're still like racist. No.
That's what I'm like.
Like, why is right and left?
So don't forget that.
All right. So however you memorize it, it's really up to you. What you have to know is you have to know it. Colorblind, red, green, colorblind like I am. You sit there in your first day EMT school like this for about an hour with the patient. How do I do? Yeah. If it's doing a 12 lead, they want on wrist and ankle according to the hospital stuff. I'm gonna tell you in the field, I don't care. Just don't do this stuff because you're gonna get bad pictures. It shrinks the picture, and so then you get false elevation. I'm doing that today. This is what it looks like. Remember, we're looking at the left ventricle standard. 90-ish% of heart attacks happen in that area, which means there's 10 to 15% that are over on the right side of the heart or on the back side of the heart. So sometimes, a lot of times when I'm taking those non-STEMIs out of the hospital, they say it's a non-STEMI, I do my standard 12 lead in the ambulance. And if I don't see anything, I do a right-sided, which we'll talk more about. And if I don't see anything, I'll do a posterior. Because sometimes it's not that it's a non-STEMI, it's that we didn't find the STEMI. How often does the hospital do right-sided or posteriors?
I've been there 4 years and I've done one.
Okay, so it's not common practice. Here's when I do it. I'm not telling you I do it on every patient. I don't lie to you. The patient looks sick, looks like they're having a heart attack. I don't find one on a standard. I dig deeper. And I go right-sided. If I don't find anything on the right side, I'll look at the back.
So it's right side. Okay, my ass is just flipped.
It is flipped. 1 and 2 stay where they are. And then 3, 4, 5, 6 come across. We are not really going to get into this today, so I'm going to move on. Posterior is going to be a little different too. That's not a today thing, but there's what a posterior can look like. You can do some weird combinations that we're not talking about today. Woo, there we go. All right,
Here's where he writes on the board.
here we go.
On
Are we
TV.
ready?
Sir?
Here's where you write on the TV.
Okay, we're going to do this every single time. Every time we look at whatever this is, a tracing, I'm going to have you call it out. So do we have a P wave? Yeah, so that's a P wave, right? What's this? Q. Upward? R. That marker sucks. S. Yep. What's the next one?
T.
What does the P wave represent?
Arterial, no, atrium, atrial,
Atrial depolarization. The QRS represents ventricular depolarization. The C wave represents ventricular repolarization. I'm going to point out some new things we haven't learned. You ready? From the beginning to the P of the P to the beginning of the Q or the R, if there's no Q, because there doesn't have to be a Q. We talked about that, right?
Yep.
It's called the PRI. PRI, PR interval. So from the beginning of the P
Yes, you should.
to the beginning of the Q is called the PRI. Yes, you need to know this.
Let me draw it for a second.
The PRI. We're gonna talk about measurements in a minute. The PRI has to be a certain size or it's wrong. Has an issue. Oh, that next slide's trash. I take it out.
Just get past it.
I will.
You need to just go order these.
I need to put that in like the access deviation way down the road.
And you
Because
should-
it makes more sense when we talk about
You
that.
need to just delete those and just make a separate slide on those.
We're not talking about it.
Yeah, don't bring it up.
Okay,
Of course, they're gonna have questions on
the
there.
ST segment is from where the S stops to where the T starts.
Jesus.
That's the ST segment, from where the S stops to where the T starts. Here's the thing, where this S stops is really clear, right? Clearly turned sideways. Sometimes it's not near as clear. Sometimes it does one of, well, that was terrible. It does one of these. It's not super clear where it stops going down and starts turning left. That point where it stops is called the J point. Where it stops going vertical and turns more to the right is called the J point.
Did everybody get that? Because this is
Super important.
really important that some licensed medics who have been hanging out for a long time don't understand.
So between the P wave and the Q wave is where the PRI is, or the P wave and not?
He's back there.
Oh,
From the
okay.
beginning of the P wave, the beginning of the Q wave is the PRI. That's not what we're talking about. You got that part?
Yeah, I'm sorry.
You're
No,
good.
I'm sorry, you're not bad. I just don't want you to, did you get the next part?
No.
That's why I'm status checking. I'm not trying to hit you. Okay, so from the beginning of the P, the beginning of the Q is called the PRI. Everybody's good on PRI. Because I'm gonna move on back on to this SC thing. The flat part between the, well, it's not always flat, where the S wave stops and turns more sideways. So it's coming up, and then at some point here it's really clear. It's gonna turn sideways. That point where it turns is called the J point. It's not as clear here, is it? Put our baseline in here. That's called our baseline. Go like that. It's not perfect. But where I see that thing start to lean out more that way, where it starts to go that way, that's the J point. And in a minute, we're going to measure how tall that is off of this baseline. Because that's how we measure ST segment elevation down the road. But we're not there yet. That's the J point, where it starts to turn sideways. It's not always clear. Super easy here. That is the ST segment. Wherever the J point is, to the beginning of the T wave, is the ST segment. And that's where we're seeing, is there elevation or no elevation? We'll let everybody catch up, and then we're going to talk about the next thing. And we'll reinforce this. If you're like, dude, I'm so lost, and you just keep talking, everything gets reinforced. Everything gets built on.
If I don't understand the brick, how can I build that?
Yeah.
It's all right.
Faith, you good? Nate? Kennard? You good? J point, ST segment, PRI. Yeah? Bridget?
Okay.
J point is just for your elevation.
Your J point is where your S wave stops, turns, and starts turning sideways. Because it's not always elevation. Sometimes you have no elevation. Sometimes you have depression, but it's where.
Sometimes because it like looks like swimming.
What was the question?
Do you have an example of one that's
Yes.
harder?
We'll do it.
So for the J point, is it not then touching the ST thing? Because it looks like it's in the same, I mean, I know that.
It's where the ST segment starts.
So how,
Okay, so it's the part in which.
The J point is the point where the ST segment starts, where the S ends and the ST segment starts.
so your QRS, your big old up downs, right? Okay, when it starts to mostly go horizontal. When at that point, when it is more horizontal than up down, that specific point is your J point. From your J point, you measure your ST segment. Okay, so there's like 3 points, but they're all kind of the same.
Okay, we're gonna hit this over and over. Okay.
Kennard,
Your ST segment and.
correct.
Yes, correct. This line It's called the baseline. It's an imaginary line where there's a beat. Really bad today. But it's off of this spot right here. After the T wave or before the P wave, that's where we measure baseline. Baseline is also called the isometric line. I'm sorry that there's so many names for everything. It just is what it is. ISO, metric line. But the baseline is what we measure off of. So if we're measuring vertically, we're comparing to the baseline. Sometimes the baseline's a little wandering, and that means we might have some artifact. So you're focused to stop touching the Excuse me. So we have several things up here. We have P wave, we have our QRS, we have our PRI, we have our J point, we have our ST segment, we have our T wave, and then we have baseline and or isometric line. We're not there yet.
Could you explain what what is it? PRI abbreviation?
It's the PR interval. And you're like, but Nick, there's a Q, but the Q is not always there. We don't call it the PQ interval because the Q is not always there. So we call it the PRI. You don't always have a Q wave. Joey, did I just no? Okay, your face looked like I blew your mind for a second. That's just okay. Cool. Good.
His mind's always blown.
That's what you made.
Yeah.
Yeah. We might have to clean this TV. That's not.
Oh, we might have to clean this TV?
Andrew, you might have to clean this TV.
That's what I thought.
Okay. All right, cool. So your EKG prints out on graph paper. The graph paper looks something like this. Okay. Let's go there. That's a good slide. I'll come back. All right. Graph paper. Let's ignore the beats for a second. Each one of these small, tiny little squares is 0.04 seconds in time. When we're measuring sideways, we're measuring in seconds. 0.04 seconds for a small box.
What is the paper called?
Graph paper.
Graph paper.
0.04 seconds for a small box. There are 5 small boxes going across to a large box. Does anybody have any idea how many seconds are in a large box? 0.20. That's just simple math, even if it takes you a second. We're just going sideways. We're only measuring sideways right now. We're not measuring vertically. All sideways measurements are in seconds. So 0.04 seconds for a small box. We don't need the big boxes. It just makes viewing it a lot better, right? If there was no big boxes and you'd be trying to count on those small boxes, your eyes would be going crossways. The big boxes just make things easier. But if it's a full big box, it's 0.2 seconds. If we're measuring vertically, meaning upward, we're going this way in boxes, that's 1 millimeter of elevation. So we measure elevation vertically, vertical stuff in millimeters. Seconds are sideways, millimeters are vertical. And I know you guys are starting to get close to being maxed out. I understand. We got to push a little bit farther because we got behind. I try not to go more than you guys can handle in a day. Seconds are going across. Millimeters are going vertically. Okay? Everybody good on this slide for now? No?
How much of a full box going?
Going vertical,
Yeah.
1 millimeter. Going up, we're going in millimeters. Going sideways, we're in seconds.
I just get it.
And what? Tiny box is 1 millimeter upward. We don't have, I mean,
Like the tiny box in.
huh?
So going 5 up out of the total, what is that?
5 millimeters.
Oh,
Yep, you're fine. It's just, yeah, I never even think about that because we don't really measure vertically in big boxes normally. But yes, it is true. Is everybody right with me? We're gonna go back a few slides.
You're gonna erase that stuff, right?
I don't know. Because it's gonna apply in a few more slides forward. Every time we do a 12 lead, this is our 12 lead paper. Every time we do a 12 lead, what we're seeing, it does depend on the monitor, but the vertical columns are at the same time. So column 1 on most monitors happens, and then column 2 happens in sequential time, not at the same, not identical. So if second 1 through 3 is the first column, second 3 through 6 is the second column. Second 6 through 9 is the third column, and second 9 through 12 is the fourth column. Some monitors, and I think it's life packs, hit all 4, it's a snapshot. All 4 columns are the exact same time. Don't quote me on the life pack, but
I don't think so.
I think life packs hits you, what you see in column 1, different view, different picture, is the exact same thing as you see in column 2. Zoll's and Phillips, Tempest, they're going in time. This is a snapshot. This is 3 seconds later is a snapshot.
Is that better than?
What?
Is that better than? Because it's.
I like across time better. For the most part.
Because we have a life pack, so then it's the same thing, just.
Here's the problem with both systems. On a life pack, if you get a big old PVC, you see it across all fields, and you're like, that was a big old nasty PVC. I'm gonna retake them. On the other style, I see a PVC. I'm like, man, most of my 12 leads good, but this section, I can't tell what the hell happened because I had a big old PVC. I had an extra bead in there, and I really don't know whether or not I have elevation because all I saw was a big old PVC. I'm not saying really which one's better in that situation, but you're like, oh, I'm gonna get a new one, or I'm gonna get a new one. Like either way, I'd like to get one without that big nasty bead, preferably, personally. Okay.
Is how you read it changed too, or no?
No, not really. So each time there'll be a little, it'll print this little calibration box, and it'll tell you how fast it's moving and how zoomed in it is. That's called amplitude. Traditionally, we don't mess with amplitude. Okay, amplitude would be you zooming in on your 12 lead. Let's just not worry about that for now. We'll talk about it next week. But if you had really tiny PRSs, low voltage, whatever, we could theoretically zoom in on it. We're not going to worry about it today. Okay? If you have questions about it, save them for next week. This is a great slide without the words, just no words. Okay? This is everything we've already talked about, except we're adding R to in here. This is actually a good one, like, yeah, take a picture, a minute. But it's just showing you what's happening. This is your heart, right? P wave firing, atrium depolarizing. Electricity is coming through the atrium. That little tiny spot right there, that's the AV node holding the electricity for a second. Right there. QRS, ventricles firing, and then repolarizing. It shows you the ST segment. This R to R concept we're going to get to, and we want to make sure that's equal each time. If the R to R is equal, we're in business. It's a regular rhythm. Normal beats are occurring. If it's irregular, meaning all over the place, we're not in business. That's hard to tell because she didn't have any funny little beats going. But all right. Anyway, this is just, we've already talked about this, okay? Just remember, when we're looking at baseline, where do we get baseline from? Before the P wave or after, yeah, right here, okay? We don't go with it here. People will try to use that. That guy can move a little bit. That can slope up or down. Not a good judge for baseline if it's moving. Because now you're like, ooh, my T wave's up. Well, your T wave wasn't up. Your PRR was a little down. Okay? So don't use that guy. Once again, a trap that medics, senior medics will fall into. They'll try to use that segment. Nope. It's before or after the T wave. I'm sorry. It's after the T wave or before the P wave. Okay, there's that PRI. Here's what I need you to know about the PRI. You need to write this down. It needs to be less than 0.2 seconds. or 5 small boxes. Or 1 large box. It needs to be less than or equal to 5 small boxes, 0.20 seconds. If it's a little too short, it doesn't matter, it just can't be too long, really. 0.20 seconds or 5 small boxes.
What you doing? Gonna swipe away?
See if it comes back. I was gonna show you something. It's inappropriate.
That tracks. We'll grab your a second. I think the balance about right there.
Strange enough, that was the videos I was just watching.
Nice. Good. Everybody good on the PRI? Less than 5 small less than or equal to 5 small boxes. All right, I'm gonna leave our drawing up here for a second. We're gonna take a break after we do this slide. We do have roughly 24 slides to go or something like that, but we've been doing better on time, okay? So call it out. What do we got? We have P waves? So everybody understands that's a P wave. P wave, so on and so forth. Do we have QRS? All right, QRS right here. What's that?
T wave.
T wave. Okay, so we have P waves, we have QRSs, and we have T waves. We want to look at our R to R. Does this right here look the same as this, as the same as that? Okay, so our R to R is regular. So what kind of rhythm are we in? We don't know rate yet. We know we have P waves, which means we're firing out of what node? Sinus node, which means we're in some sort of sinus rhythm. That's it. Okay. Sweet. So we're in some sort of sinus rhythm. I can hear him. Clarify.
P wave. Sinus.
For today, that's the answer.
No, don't do that.
Sorry.
I want to be able to write something down that I can look back.
The answer is yes, but there are add-ons that can complicate the answer.
Okay.
We're not anywhere near the add-ons. Sprinkles and sugar on top stuff, we're not there.
We're baking the cake.
But the bass letter, yes, it is a bass rhythm of a sinus rhythm if there's P waves. Lots of sprinkles and add-ons we need to do. So we know we're in some sort of sinus rhythm. We could be in sinus brady, sinus tach, or normal sinus. Now we're going to check rate. I have not taught you how to figure out rate yet, but I'm about to. And we're going to take a break so your brains can take a breather. This right here is a 3-second marker. Between here and here is 3 seconds. We don't really we ideally like to have 2 of those, a 6-second time frame. If we had 6 seconds, we would count all the beats in 6 seconds and multiply it by 10. The 6 times 10 is 60 seconds. That gets us to how many beats are in a minute. So if we had 2 of these, which we only have 1, but if we had another one, we'd count the beats and we'd say, well, 6 times 10 is 60 seconds. So number of beats in 6 seconds times 10 is the number of beats in a minute. Just like when you're listening to lung sounds. None of you listen for a minute, don't lie to me. You probably listen for 30 seconds at best and multiply by 2. It's the same concept. How many beats do we have? In a 6-second time frame, we're going to multiply by 10. So here we only have 3 seconds, so we have to multiply by 20, and it's not near as accurate. So between here and here, how many do we have? Huh? 2. Between this marker and this marker, we have 2. 2 times 20 is 40. Everybody agree? So it could be 40. Here's the other way, and somebody's going to freak out. Deep breath. You just have to memorize it. It's not as hard as it sounds, I promise. You try to find the beat that lines up with the darker line. It just makes it easier. If another beat hit on the next line, that would be a rate of 300. But it didn't. The next line after that would be a rate of 150. But it didn't. Then it's 100. I know that math's different. Don't lose your mind. Then it's 75. Then it's 60. Then it's 50. Then it's 40. Then it's 30. Then it's 20.
He'll come down there and write on that
Okay.
too.
So I find the beat that lines up with the line or is close to it. If a beat fell right here, right there, that would be at a rate of 300. If it fell right here, it'd be a rate of 150. Then 100. Then 75. Then 60, 50. Then it goes down by 10.
Yes.
You don't You just have to commit that to memory. You're like, why would I ever use this? A, my monitor tells me a rate. Well, your monitor's wrong a lot, specifically on irregular rhythms. Let's just get that out there. The bad thing about the 300 method that I just taught you, it only works on regular rhythms. Here's why. On an irregular rhythm, let's say there's a beat here, and you did it right there, you'd be like, that's 300. But then it goes back to normal. Well, the rhythm is not 300. You had one tiny section that was 300. That doesn't work. If you use this method and you get that funny little beat, it still kind of evens out over time, especially if you get a big enough strip.
So this is called the 300 method. Most medics will use this fairly consistently when you're looking at stuff, when you're looking at rhythms and that sort of stuff, just trying to make sure that your monitor is correct.
I use it all the time.
I use it all the time.
All the time.
And we talk about a lot of numbers, but you really got to memorize the first, 4 or something like that. 300, half that 150, 100, 75. Once you hit 60, you go down by tens.
Super easy.
So it's really, you just got to really memorize the first 4 or whatever it ends up being, right? And just like Nick said, you're going to look for a QRS that sits to as close to this line as possible, right? Because that just makes things easier. If I was to sit here and use this one, then I have to kind of be like, oh, maybe 300's here, and then 150 here, and then 100 here. But then what if this beat comes here? Then you're kind of like in between all this weird stuff. So just look along your strip somewhere. Try to find the one as close as possible. If this was as close, we could use this one here. Like, okay, like I could probably work with that. 300, 150, all that sort of stuff.
And you want to base it off of that.
Yeah, just the QRS is going to be the easiest thing for you to do because these lengths can switch. The QRS, as long as everything's regular every single time, forever,
It's just a rate.
right?
So
As long as it's regular the whole time,
PRI on this.
you can use the 300 method.
No, absolutely. I'm more so like, does it need to be like the?
That's what I would fixate on, about 5 minutes, like I doesn't have to say it.
Like, I'm a little confused on like which one.
Like which part of the QRS?
Yeah.
Just find the point that is the closest to the line. Don't use like this part of the line. Try to use
60
like
is
the
right,
point.
really close to where it is.
The point is just going to be the easiest because it's going to be the most like
Yeah, maybe
clear.
And you mean like the actual?
Just barely.
That's
Yes.
referring to like the like the fucking. S-way.
No, I'm looking for the pink point. That is an interesting question that Tyreek had. That is an interesting question Tyreek had. When we're doing this, we're using the point of the top because then it's extremely clear what point we're looking at. Because if you use some weird line like this, oh hey, this hits right here, so I'm going to use this point. This thing can change shape.
Because I thought at first you were more so because it was not on the point, but because it was in between.
No, I was looking
that's why he picked it. I was like, oh.
I was looking at the point.
Okay, my bad. Yeah.
No, you're good. So, yes, let's go over that one more time. We use this method, which is not very accurate because it's such a small amount, and we got to 40. We use the 300 method on a regular rhythm. This is a regular rhythm, and we're like at 58. We're just under 60. The difference is dramatic. Could be at least, depending on the patient. Could be different rhythms completely. Okay, so this is more accurate, especially if we have a small sample size, as long as it's a regular rhythm. If it's irregular and the beats are all over the place, you have to go back to this method, the 3-second or 6-second strip. Okay, if it's a 6-second strip, meaning we have 2 of these 3-second markers, we multiply by 10. If it's a 3-second strip, we have to multiply by 20. Okay. We're close to a break, I promise. Not today, Isis. Nope, not at all. Nope. Already talked about that. That all looks the same, doesn't it? Cool. Lots of words though. They love words. They just think words are the bee's knees. Yeah, we'll come back to QTI too.
What's the importance of the ST signal?
That's where we decide whether or not we have a STEMI. ST signal, elevated myocardial infarction. That's where we decide that. We're not to STEMIs yet, but we will get there.
I'm gonna just write that down.
No, you're fine. You're fine. This is a good break. Let's stop. Let's take a 5-7 minute bathroom break or whatever we need and come back. We are still pushing for another roughly, what is it, 20 slides?
I mean, a little less, but yeah.
A little less than 20 slides. We'll be fine, but
22 slides.
so this is heavy on application, so we do not go fast on the next parts.
So you said.
So STEMI is STE. Right? What STEMI stands for, that's what we're Yes, the ST segment is how you will identify a stem. Is the portion of the lead, or is the portion of the trace that you're gonna be looking at to identify a stem.
It's the part that's gonna be elevated.
Yes. The name pretty much tells you kind of how it looks. Like ST elevated, ST elevated myocardial infarction. If that portion is elevated to a certain threshold, to a certain definition, you are having. There is an indicator that you are having a STEMI.
But after the R, they come back down, just pop back up right away, or what's
So there's not always, we'll show you, don't get ahead of us.
I mean, I can't go home and watch a YouTube video more about it, cause like I still feel, even though the stuff we're saying, I'm getting.
So I would, what I would seriously do with this sort of stuff is go over our notes. Go over our notes and what you've taken the notes on, and be really comfortable with what you've taken notes on. And then when you come back next week, like you said, 1 or 2 hours on the very beginning class, we don't have a test beforehand, 1 or 2 hours beginning class. We're going over all this stuff again, and then we're gonna add on top of it. Wait 3 or 4 weeks until we start YouTubing shit. Just so that that you know how to start to identify a rhythm. And then from there, you can kind of like play with it. Okay.
Well, I know we're not supposed to get books, but what was the book that you were saying? Orange book?
It's an orange, I have it in my office, it's an EKG.
It looks really old. It's like a buyer, right?
It looks,
I'm gonna buy it right now.
it looks really old, but it's one of the most comprehensive ways to.
We have one at the station.
Yeah. It's a good book. I'm not gonna look at it.
Exactly.
Stress it out, dude. I can already tell it's gonna be so fucking. God.
I might get a road beer on the way home.
Honestly, I might get a road fifth of Hennessy on the way home. That's how you straw on it.
Get pulled over, like you been drinking and driving, brother.
Honestly, I've been driving and drinking, let's be honest.
All the way home.
So, look it up, order it if you want, those sorts of things, don't open it. Until, don't read it until we give you some.
He said, don't open it. It's
The first thing. But buy books. So I bought this book.
This is, if this was like one of those things, this is EKGs for dummies.
Yeah.
That's what this book is.
Yeah, I'm definitely.
I'll read that.
If they have EKGs for dumbass.
Yeah, I might need that one.
No, it's EKGs for the autistic.
It's like pop-up pictures for me.
That's right.
This is what an inbox smells like. I'm like, oh, blue's clear. Can you find the FC segment? I'm like, shit.
You can go to spellstat.com too, and just like common rhythms.
Oh, I bought those with skills. I'm gonna need you to say that when I get back to this pee. Keep that in
How
mind.
much do you pee in a day?
I drink about a gallon and a half.
Oh, we ain't even done with this thing yet.
Baby sliders.
I'm about to say, I drank like that this morning, I already drank one, and I'm about halfway through that one.
Yeah, still stat.
On Amazon? Yeah. I think Barnes and Noble for that shit. They gotta be selling shots at the counter, so I'm sure. Maybe.
I'm sure they don't want us to play yet though, because it's, we don't know.
The only thing I got
It's
from
too
this
soon.
part of the lecture was the 300. It's close down.
Anybody else's brain?
My part before we go on.
That's fine. It's really good.
Mine was much when I took that test.
Yeah, mine was toast.
It did, that's what I
And actually just sleep.
6
We ran 2 after 1. And I didn't go back to sleep after that. Yeah. Oh, really, you guys? Like fucking. I did what you did last night. All my calls. Like, oh, we're going on that.
So what is it? Yeah, so I actually ran a call, in Henry County when I worked at Glen Valley, and the guy was having a widowmaker pacemaker, so I wrote. That was my executive summary, was the basis of that call. And I was awarded $867,000 in Gates County, so I coordinated with
I don't know.
agencies to split up the money. Because we didn't use it, we were gonna lose it. So that's what it is.
But it's slowed down. I want to.
They are,
Even though
yeah.
you're.
So we got a
Okay.
whole bunch of training, you know, the elderly women that did airways.
When do you guys like go and do your?
So they make it.
Whenever you get time.
Yeah, it's, our, at least ours works at like our
For
captain's
15%
nutrition. Yeah,
off.
we have like a set schedule,
Yeah, so.
each day. Yesterday we did, like
I knew these.
PAL stuff,
And then, like, Eagle.
but we ran all day to get to it.
That's so nice. I wish Dave had that.
And then.
It's a lot, man. We like, they take away our deal. It's not.
How was your drive this morning? I'm pretty sure we're not allowed to put on it.
Bro, I did my top.
Yeah, I haven't seen you in like a month.
The other day. You're next year, right? Like, yeah.
Just got one of
Like,
these years ago.
all right, let's do medical school.
I mean, I could.
What the fuck, man? So by the end of the year, bitch, I didn't. So like, for 2 of them, she watched me do a crack on the menu. I'm like, shit, I got this big trick. All right, you look at, what's went over like, sedation stuff on, hold up. You're like, oh, wait. EMT still. The fact that she's like, actually, we're gonna start testing you. You're doing great. Oh, you're doing great. I should be doing that medic competencies. Yeah. Like, bro, I would stress. I can't practice in front of people I don't know. It would like make me tweak out because I'm like, oh, she's gonna think I'm a fucking idiot. If I mess up. There was like 8 other people including the competency. Watching on one mannequin, I was holding the freaking ring scope like this. I was like, all right. Bro, like when she stared at me, like with her notepad on her hand, I'm like, oh, yeah, this is.
Doing anything here physically in person does not, I don't ever get nervous. I don't get like if we gotta do an interview, like it doesn't bother me. I get hella nervous when people are gone. It's like, oh shit.
They're gonna clown me so hard.
That's exactly what I'm thinking. I'm like, they're gonna be like, he's a fucking dumb.
It's actually 15 liter.
It's everything that I know. Bro, literally, like if somebody said that to me on the test, I'd be like, oh shit.
Wouldn't even bust it up, walk out.
I remember when I went to get my EMT license and I was hooking up to do the EVN, like attaching it to oxygen. And I was doing it in front of the dude and I attached it to oxygen or whatever. And then I look over at the guy and he was like, are you sure you're supposed to do that? And I was like, I shit you not, I have no idea. Yeah, I was like, I don't know.
Can't go back now.
Yeah,
It's already on.
He's like, I don't mind looking like a dumbass in front of people I know, but if it's a stranger, shit.
So it was really funny when I was doing the stuff here to get hired. I was doing part of my practical training stuff in front of Dustin and Ben. They were both in the same room, and they were like, "All right, you need to place a BLS like advanced airway kind of thing." So one of the combi tube, they only had out a combi tube, but I'd only been training on the Kings, and so I was like, I don't know what to do. So and if you guys don't know what a combi tube is, it's the same type of deal. It has the 2 bulbs, just like a King and that sort of stuff does, but it has 2 ports. I had no idea which one I was supposed to like breathe first. So I just shoved it down and pumped it up. And then I was like, all right, and you're going to breathe here. And he's like, well, what if that one doesn't work? I was like, then you breathe here. And they're like, really? And I said, seems like it. I don't really know. and And then I got hired, so I was like, what did I?
It's been the right answer.
What stories are you telling
When I was getting hired here,
originally?
yeah, I was doing one of the testing skill stations was to place a combi tube, which we had never trained on. And it was in front of Ben and Dustin. And so they were both in like bedroom 2 down there of Old House 1. So I placed it because I was like, okay, this is just like a king. It's just got 2 ports. And so then I just attached to whichever one. I think I attached to the bottom one. And I was like, all right. And then you ventilate here. And they're like, oh, okay, cool. What if that doesn't work? And I was like, I can just take it off, put it on this one. They're like, you sure? I was like, I don't fucking know.
But that's my one good thing in my life. If I don't know something, I'll never lie. Like I'm not gonna. I don't want to get in a situation where people are gonna ask me something. Bro, it could be something I'm like super confident, and I would still somebody questions me on it. I'd be like, I've been training on for 8 years. Truly, I would still be like, shit, I don't know. I don't know. I don't know.
All right.
Put your sock on left versus right. And they're like, is that how you do that? You're like, yeah, I don't know.
They're like, are you supposed to wear a shirt today? And I'm like, okay, say, what is your shirt? It's like, I look around first.
I feel like Tyreek, you're gonna be the like literal one. We're gonna be talking about. All right, guys, we gotta get this mannequin undressed. We turn around, Tyreek's just getting undressed.
All right, we're starting with our big sheet. The top box, as high up as you can go, kind of center, not really under the word cardiac. Would say P waves question mark. P waves question mark. Here's the thing about this. Eventually, you're going to get a filled out set by printout. This is how you walk through and take notes. On this version, I have medics that still keep these in their bags. You can't do that. You got to memorize it, but like you can, but you can't use it to get through class. You have to use it for a few weeks, and then you'll have to have it memorized. It's a really good way to learn it, to get it committed to memory on how we analyze rhythms. This is how we analyze bass rhythms, not how we analyze 12 leads. How we analyze the bass 3 lead, what the rhythm is. That's what 3 leads are good for. Rates and what's the bass rhythm. 12 leads tell you the fancy sprinkles, semis and other branch blocks and all that stuff. The bass rhythm is off of a 3 lead. And the first question is always, do we have P waves? Okay. So if the answer is yes, going left, say yes for P waves. So we're going to look at this rhythm here. That's where I said things might slow down a little bit because we got a lot of rhythms to look at. Do we have P waves?
Yes.
Yes. Hey, to your point earlier, a lot of these, it looks like they took a generated rhythm and stuck it on the paper instead of having an actual printout scanned in. So you might find some weird stuff. So yes, we have P waves. Okay. The next question under yes, we have P waves is the PRI equal and normal? So we put it in this box, PRI equal and normal. You can run off to the side. Has to be both equal and normal. So what I mean by that by equal is it the same each time? Is that the same? Is that the same? Is that the same? And if the answer is yes, they're equal. Is it normal? Normal means less than, well, how many boxes? 5 small boxes. So I count this one out. Remember, we're starting here. Beginning of the P wave. We're ending at the beginning of the Q wave. 1 small box, 2 small boxes, 3 small boxes, 3 1/4 small boxes. Is that equal and normal? Yes. If yes from here, we're going down to sinus. Some sort of sinus rhythm. Some sort of sinus rhythm.
Oh, and then the rate, so it's.
Then we're looking at rate. We have a 3-second strip here. Guys, see that? 3-second markers? My eyes are looking at the screen for too long. 1, 2, 3, 4 beats. 4 times 20. 4 times 20. 80.
Are you sure, Tyreek?
80 falls in normal sinus rhythm. All right? because that is 62, 100, normal sinus. Let's double check that with the 300 method. When I do the 300 method, I might say the first number, but I expect you guys to take over farming. So I found one that lines up with a line. 300.
What is the 100?
So 65-ish?
Yes,
65-ish.
you're right, Tiger.
Sweet. 65-ish, very good. So I do that every single time. I know it's annoying. We will try, if you will learn. You ingrain it in your head, because I'll make you say it out loud so many times. And then underneath of all this, there's an R to R question mark. Hey, is your R to R regular? Is this right? Does that match that? Does that match that? From the top to the top? Do those match? A lot of times I'll take that same paper you're using and like realize you'll see me do this a lot, and I'll line it up. I'll use the edge of one side and I'll put a dot on the other side, and I'll just make sure it maps. Sure does. R to R is regular. We're good. So that is normal sinus rhythm. Cool. We got
Then the allowance PRI.
do what?
Other than the lengthened PRI.
This one's normal.
Okay, I didn't count these.
Yeah. You were talking about,
That other page.
I don't know how many students like that.
Yeah, this one is
Going all the way back there.
just what Reebok.
All right. How about this one? Do we have P waves? No, we don't. Okay, we're not doing this rhythm today. We're not going to figure this one out. We will do it later. But that question would take you to the right side of the board of, no, we don't have P waves. And we have a whole nother problem. Are the R to R's regular? No, they're not regular. So anybody, do you want to guess what this rhythm is? It is irregular, but what rhythm would that be? These are what we would call narrow QRSs. They're not too wide. They're close. They're
like miles.
They're supposed to be narrow. They superimpose it a little further. They're supposed to be narrow.
Number one.
We'll talk about that more later. This is AFib.
That's
But
eighth.
it is AFib. It's not perfect. I should have said it. All right. Do we have P waves?
Yes. Kinda, yes, is that a P wave?
This
Sometimes.
is fun.
I think so, I would say yes to a P wave.
Yes, we have P waves. Is our PRI equal and normal?
No, not at all.
So fun. Can we identify any patterns or repeats of weirdness? Any funny little beep?
Does that one have two tips? No, there's two
There's
of them that have like
your
two.
marker on the board?
No.
No,
Okay.
that's there. That's like that.
It's like two spikes up there. Yeah. How does that even make?
These next 3 weeks are gonna be fun for him.
Aren't those?
No, why are you saying that? I'm getting nervous.
All right. My feet hurt.
I know.
This is why you wear the comfy shoes.
Yes, you're
The
right.
P wave. Okay. When we look at T waves, we want to look across the board. We want to get an example of what a good T wave looks like, especially when we have funny little beats going on. So I'm not necessarily looking here because I don't know if that's a P wave or a T wave or what the hell that is. Okay. And I know that one looks funny. So I'm going to come over here and I'm going to say, hey, that's a P wave and that's a QRS. And this is actually a really fairly flat looking T wave. And I can find that kind of repeatedly, flat looking T wave, fairly far out on a few different beats. That one's really bad. There's that one.
Would the J point just be like the part that's then just that, because they all seem to just come down and stop, but that just be the J
When
point.
it turns sideways. So
It's like right there. Yeah, okay, all right. I was like,
that one's real good right there. All right. So we got these T waves. Now we're going to identify P waves. We know that's a P wave. That doesn't look like a T wave, does it? Because the rest of these T waves are really flat. That's a P wave for this beat. Okay? Which means that's a T wave, and that's a P wave for this beat. And that's a P wave for this beat. And that's a P wave for this beat. And that's a P wave for that beat, even though it happened too soon. That's a P wave for that beat, and that's a P wave. Ooh, that's really funky. And that's a P wave, and that's a P wave. So when I say do we have P waves, the answer is yes. Are our PRIs equal and normal? They're not great. I see what you're saying, for sure. Are they too long? Are they within the range of width? 1, 2, 3, 4, They're like right at 5 boxes. So it's not great.
I'm gonna go get Aubrey, move back to Boston.
Okay, thanks. Yep. So we have P waves. Here's what we're gonna do on this one. Can we identify, could we take some stuff out and it be normal in the background? This is tricky. You're gonna hear me. If I take out this beat here and said, hey, if that would have hit where it was supposed to, and if that would have hit where it's supposed to, that one's a little early too. Could we get to where we were normal in the background? Can we identify a pattern here? Looks better. So what we have is
Oh, you're specifically referring to the.
this beat here was too early.
Okay, I was like.
And that beat there was too early. And technically this beat here was a little too early. Those are our 3 funny little beats. What I'm telling you is behind the scenes, behind those 3 beats, we had a pattern. It was normal sinus rhythm, or what I think rate-wise, let's check 1, 2, 3, 4. Yeah, it was normal sinus rhythm in the behind the scenes. These guys hit early. There should have been a beat like right. Let's do our R to R. There should have been a beat like right here. Same thing. Should have been a beat like right here. It came early. It's a premature beat. Sorry, you want to throw that far away.
Sorry, my brother texted me about phasing.
I know, that's good. But we're down here in the premature beats. When you babysit your nephew, you want to be a paramedic.
Just saying, my bad.
Now we have to decide which type of premature beats are we getting. Are we getting PACs or PJCs, which are junctional contractions, or PVCs, which are ventricular contractions? PACs have P waves. These have P waves? They have to be PACs. Because PJCs either have no P waves or they're upside down, and PVCs are wide as family. You guys are lost now, aren't you?
All right.
It's okay. These are just premature contractions. We're going to get way more into this in future weeks. So if you're getting lost, premature beats. Got a little excited, fired a little early. And when it did it, when it fired early, it couldn't fire again when it was supposed to, right? It takes a little while to recover in your thing. So it should have fired
Surprised
here,
nothing happened before now.
came a little premature, can't fire again, gets back on schedule. On schedule, on schedule. Fired prematurely, should have fired here, didn't. Now it's back on schedule. So, okay. Let's go to the next slide before I really lose you. These are just premature beats. These are specifically PACs.
I got it.
Specifically PACs, but okay, cool. Cool. We already talked about the 6-second method. Here we go. Let's get rid of that. Let's help everybody out. Deep breaths. They did leave something out here which pisses me off because they're not perfect. There we go. We got 2 3-second markers. 3-second marker, 3-second marker, 3-second marker. That's 3 seconds, and that's 3 seconds. In this case, we add that up, 5 QRSs. We times by 10, good. And we would get how many beats per minute? 50. And if so, if this is 50 beats per minute, what rhythm are we getting? Well, hold on. We have P waves.
Yes.
It's small.
There's a little one.
They're small, but there are P waves.
Small baby P waves. They are very small.
So you're in sinus.
So you're in a sinus style rhythm because yes, we have P waves. Yes, the PRIs are equal to normal. Sinus rhythm. Now we're looking at rate. Sinus Brady is this box right here. Sinus Brady. Under 60. 59 and below. Sinus Brady. Go to chiropractor.
Yeah.
Okay. That was easy, right?
Will the P wave present more shallow because it's recurring, or is that
No,
just happening?
that's just happens to be this one. No, it's not always like that. That can be me, that can mean a host of things.
So even though the P wave, on like the QRS5, how it's more of a dip down than up.
So it's tricky. You gotta start over here at baseline. There's a little hump up here, it's very small.
Yeah.
And then this is the cue. So And remember, don't ever look at one beat. Medic students they tend to grab a beat and focus on it. You gotta kind of look across and look for a pattern. Like, what does it look like all the way across? Does that P wave look like that P wave? Oh, I see it on 1. I see it on 2. Oh, I really see it on 3. Okay, 4 looks a little bit. 5 looks like shit. Same here with T waves. Okay, I see a T wave, T wave, T wave, T wave. Okay, all right, that all looks the same. So I see a lot of medic students, they'll grab 1 or 2 beats, they'll look at that, like they're trying to be really quick, and they'll miss out on the bigger picture, especially when we get in blocks.
So finding one regularly doesn't necessarily matter if the rest of them are more.
Let me say yes and no. Yes, if it's in the same spot and it just looks a little smaller, you know, that's okay. If it's in a different spot, it's not in the same place, that's a new problem.
For today, the answer is yes.
Yeah, but I don't want to like. There's the 300 method. You guys feel good about that, right? 300, 150, 175, 60. Pretty good. They found one that lined up with the main line there, and then they just counted over. It's got to commit it to memory. So that's like 65, maybe. 60 something. I promise you, you will use this. This is going to get used. It's I don't know how medics would survive without this. All right, good. We're never going to do that, so that's good. We can classify these things differently. They can be too fast, tackies. Tacky dysrhythmias. They can be too slow, Brady dysrhythmias, life-threatening, non-life-threatening. We don't really care. We normally just call it what it is, right? So, do we have P waves? Are our PRIs equal and normal?
Yes.
So I'm calling that 4 small boxes, I think, for our PRI. Yeah?
Yeah.
Good. Are our R to R's regular?
Yes. Yes.
Okay, somebody tell me the rate of that. It's got 3 beats and a 3-second. 3 second, not 6, so times 20.
60.
60. Okay. Now let's take that second beat. It falls on a line. Let's call it out. 300. So it's like 68, 65, something like that. So what is this? Greater than 60.
Oh,
Normal sinus rhythm. Got P waves, normal sinus rhythm. Thank you. Diana, appreciate it. Oh, now it's the part right. Do we have P waves?
Yes.
Are our PRIs equal and normal?
Yeah.
Yep, looks like we're just under 5 small boxes. Are our R to R's regular?
Yeah.
Yeah? What's our rate? We got, ooh, how are you gonna count that?
The first one you can do the first one. The first one.
Oh yeah, I was saying with the other way with the 3-second mark, because you got like 2.5 beats in there. You're gonna count it as 3 or 2. So 2 you're at 40, 3 you're at 60. All right, do it the other way. 300, 300, 150, 100, 75, 60, 50, like 55.
Yeah, so Brady, okay, I was right. 80. I like that.
300 helped out a lot.
300 helps out a lot.
So we're in sinus bradycardia at like 55. Faith, you got that?
Emily, you were shaking your head. You got it? We good? Okay. All right.
The focus is.
Feel better.
Huh?
Next slide.
Yeah. Kennard, you good? Nate, doing good back there? Matt, all the way over there?
Sinus bradycardia. Okay, under 60. Oh yeah, it just says that. Cool. This stuff, this information, look, there's a ton of causes of sinus bradycardia. A ton of it. We're gonna get into all that, but like we also didn't need to let it distract us today. We're not gonna talk about pacing today. That's another day, that's another day. There we go. Make that a little bit bigger, please.
I have a question that I know is like stupid, but I need to know the answer why it's this. Why is it called, like, is there a correlation between your actual sinuses and like, I just need to know, why is it called that? Why are they both called sinuses?
It's just a sinoatrial node.
God, dude, it bothers me so much. I've been wondering this from day one. Is there a correlation at all? Like, why? is
Like,
it
but
called-
like with your sinuses in your face?
Yeah,
No.
yeah. Okay. It bothered me so long. I've been wondering the whole time.
Sinoatrial node. All right, do we have P waves?
Crush your sinuses? Are
Your
you
eye
not in
equal
sinus
and-
rhythm?
Your eyes equal and normal, so we're in some sort of sinus rhythm. We're gonna check our R to R's, make sure they look regular, and they do look regular. And then we're counting our rate. We've got a 3-second strip. Is that six beats in 3 seconds?
120. Yeah. Hey, okay. Coolio, that's what I'm thinking. Same.
120,
Yeah.
which makes it.
Bro, low key, put me in a cat lab right now, dog.
Well, let's start by just putting you in an ER. Just let's see where we go from there.
Science fact. It is. You're getting real close.
Yeah, we are.
Good stuff.
I got a few more slides.
Great. Remember, we're gonna go over this again next week very thoroughly, so I don't lose anybody.
I'm okay with
It's,
this.
it's clicking a little bit. The 300 is helping a lot.
Here's the other thing, I didn't mention this. Guys, in med school, some things may click fast for you. You may be great at airway. You could be the best brand new innovator that I've ever met. Okay? And then some of you are great at IVs, and you're like, man, I'm the bee's knees at IVs. I didn't even mean that. That was pretty cool.
That's pretty good.
Yeah. And then you are going to struggle with something else. So you may be great at cardiology. You may be the superstar at cardiology. Help your peers, because they aren't all. And then you might suck at IVs. You know what I mean? Like, no, I've never yet met a student that aced everything. Like, he works here. He's stupid smart. It's annoying how smart he is. But he's not very good at innovating. He's not very good at innovating. Like, he's great at all these other things. He can tell you about
What the heart's doing, all of it.
I mean, just like to a molecular level, he can tell you stuff. And it's okay. Like, no one is good at everything. My first 2 years, man, I'd shanked probably 60% of every IV I ever started. It was just like, no, that one sucked. I'd blow the first two, like, eventually, and then I'd sink the hard third one. I don't know. It was just, I was terrible. I went too fast. When somebody finally said, you just need to slow down and let your arm feel a little bit, chill out, and actually size up your arm instead of hitting every AC and blowing all these ACs. And I actually slowed down on these old people with their weak ACs, and like, well, I was, whoa, my IV success rate went way up. So I just want to point out, like, if you suck at cardiology, take a deep breath and use your peers to help you, to learn what they're learning. If you suck at IVs, take a deep breath and take some skills from somebody else, because nobody's good at it. All right, I'm done myself. Lots of causes of sinus attack. Okay, we're gonna get into that more later. We got too little potassium, too little calcium, speeding things up. We could be hypoxic. We could be in shock. All kinds of good stuff. Zoom in. Any room? Do we have P waves?
Yeah.
Are our PRIs equal and normal?
Yeah.
Yes. So we're in some sort of sinus rhythm. Are our R's equal? Can we identify a pattern or change?
Change it. Yes.
What do you mean? What are you seeing, Tyreek?
Like where it drops.
What's going on? What's happening? What's the pattern? What's the change?
The middle part is like, for one, it spreads out, so it's wider. So it's wider for one, and then two, it's like, maybe it doesn't matter, but to me, it like looks like a drum slope.
When your fifth and sixth beat, you have a longer.
There you go. He said.
So if I do this, guys, if I do this right here, are you saying that's fine? No. What? No? I didn't know.
The in between.
Why? Your T to P is longer. P to P is long. No, I know. But is that side? What rhythm is this?
Sinus.
Do you have P waves?
Yeah.
You have QRSs and T waves?
Yes.
Are your R to R's regular now that you're over here?
Yeah.
I mean, it goes from 6.
Go. What he's doing is cover this. Forget this.
Go
Go from here this way.
Like,
Oh.
yes, that's good.
Yes. Yes.
So check your rate. 300, 150, 100, 75, 60, 50. Did you see that? Now, cover the opposite side. What's that? So are you saying we went from normal sinus to sinus Brady? We just had a rate change? Maybe they took a deep breath, calmed down a little bit. So this is a EKG I would rip and throw away in real life, quite honestly. I would have the pre-rate, the normal sinus, and then I was like, yeah, this is what they got, what we got, and then they take a deep breath and they went into this over here. Normal sinus, that's great. But all this is, they're gonna call it sinus arrhythmia. It's not on your sheet if you want to write it lower. It's kind of a catch-all term that I don't like very much. Or it changed. But it's really just a change,
This is a good one because you gotta stop and think about what's going on. You look at that, you're 100% right. It looks like you dropped the beat. And if it looks like you dropped the beat, we're talking about a different type of rhythm. But cover this up. Over here, before this, looks totally normal. Cover this up, before that, looks totally normal. So we're taking a step back and we're identifying that bass rhythm.
If this was doing this, and then did that, and then went back to this, different problem, most likely.
So, hold on, wait.
It wasn't a rate change at that point.
So then clarify, so whenever it switches to a slightly different rate, but then it keeps that consistency, like
That's
stays
the-
throughout, then that's okay. But if it changes like that and then goes back, that's a problem.
Different thing.
Okay.
And there's actually a couple different things, so that's why I can't answer like the why or the what. There's a couple different things.
But because this rhythm and separate this rhythm are normal, not a problem.
Just a rate change, no big deal.
Okay. You can do this and then hit this and do something way different. Way bigger problem, way not today. But because
But I wouldn't even call this a sinus arrhythmia.
Yeah.
I mean, it technically is. I would just call it rate change. We were in normal class, we went to sinus Brady. Have a nice day. Two different things.
Yeah. Because they didn't go to a sinus
Yeah,
break.
right.
So,
Yeah.
when we
It's
did
smart.
this,
And that's
we did
just
rhythm
as simple as like this right here is as simple
like
as
platinum.
they were
Not probably, you will get some on platinum, not many on platinum. There'll be a lot of other resources we'll use.
or they were holding their breath and then now all of a sudden they let their breath out and then that's
Or this is a kid. Kids do this all the time. Kids' heart rates change with breathing so often. So, not really. Okay? Simple, they're gonna call it a sinus arrhythmia or sinus dysrhythmia. It's the same words. They just use them interchangeably.
No,
We're all set.
I've seen this in real life and I'm like, hey, what's the problem? And mother's like, don't try that.
Sounds like a good plan.
Hey, what does this mean, you stupid bitch?
You know, can I tell you who responds that way? The people that respond to questions with stay in your lane, shut your pie hole, whatever that terminology is, those are people who are not confident in their decision making. I love when my EMT, thank you. Yeah, when my EMT partner asked me questions, dude, it was the best thing ever. I love to teach, and I'm confident, clearly, probably too much. I would just tell him, it was like, I had a partner once, and he was pretty adamant. He was like, you missed a STEMI, that was a STEMI. That was a STEMI. You messed up. Like, he was really over. It was okay though. You know why? Because I actually know what I'm talking about. And I was like, no, you're wrong, but it's okay. He's like, no, you missed a STEMI. I'm like, no, and we'll talk about it when we get back. Okay. So I showed him. And I told him, and I can't tell you yet because we're not there, but I explained why it wasn't a STEMI. And it never hurt my feelings one bit that he asked a question, that he was wrong, anything. It didn't matter. Because I'm confident. And when you get to that point, you'll embrace questions. All right.
I had
That's
another.
exactly, that's all ego to get pissed off about that.
We have leadership like that.
Those are people that don't and shouldn't be where they're at. They might have been promoted too soon, you know?
Yeah.
I'm not speaking to any person.
Me neither, I'm just.
That changed.
Because at least one of those people I think trained here.
So for a second, it looks like their heart.
Oh,
like
not
went
him.
I mean, there's
Not him.
her.
Yes.
It looked like their heart like went asystole for a second and just stopped.
All right, let's talk about this one. Do we have P waves?
Yes.
When we have P waves, is our PRI equal to normal?
Yes.
Under 5 small boxes, yeah? Good. Okay. Close, but it's under. So yes, we have P waves. Yes, our PRI is equal to normal. Is our R to R regular?
I mean, from there to there, no, but from there to there, I guess, if that like.
We should have had a beat right here, right? We have no P wave there. That's really important. There is no P wave there. This is gonna, and it's also important. This was doing this. Over here, it was doing it, and it went right back to the exact same rate on both sides.
That's
So
a problem.
it had this over here, and it has this over here forever. But it had that gap with no P wave.
That's not good.
It's not. This is called a sinus pause or a sinus arrest. The SA node was supposed to do its job. It was supposed to fire right there. There should have been a P wave and a QRS, but the sinus node did not fire. SA node did not fire. It didn't get slow enough before it did fire again for the AV node to kick in. So we just had a pause. And this is what doctors are going to start saying: sick sinus syndrome. Their pacemaker. You might need an artificial pacemaker. Whatever. That doesn't matter to us today. What matters is there's no P wave and there's no QRS. It was doing one thing at a rate of whatever. It took a break and then went right back to doing the same thing. So what rate is this? Let's just try to figure this out. 300. 68, something like that. So we're in a normal sinus rhythm, but we had a sinus pause or sinus arrest, used interchangeably. Sinus pause or sinus arrest.
I have.
Not on your sheet, so I would write it down below. Yes, sir. No, it's fine.
I get the 300, like I'm actually, when you're counting it, you stop at the QRS, right? Like when you're counting backwards.
Like when I go 300?
He's coming.
That's your goal.
Yeah.
You stop it when you get to here or.
So I go past it. So like if, let's say this was here instead of it being here. 300, 150, 100, 75, 60. Hey, this is probably 60.
Okay.
Because we're in between.
All right, just making sure.
So it's a good person, it's fine. Okay,
Where do you want us to rank this?
on your sheet here, I'd write it down below. Like what a sinus pause or sinus arrest is. I would also write a sinus dysrhythmia or arrhythmia down there. Like sinus arrhythmia dash rate change. Sinus pause. Took a break. Something to that extent.
You said sinus arrhythmia is rate change?
Yeah. And sinus pause is took a break. Because this is your notes page. Like you can tear that thing up as much as you want. We're going to give you a clean copy at the end. What I find is most of my students find the clean copy with all the printout and they're like, but it doesn't have all my notes on it. And they would prefer their notes page, which I get. It makes sense.
So it's.
Yeah. 104.
to SVT, right?
Yeah.
What was the word you used?
Is it dysrhythmia or?
Both. Either one's fine. Arrhythmia or dysrhythmia. They're the same thing.
Sinus arrest and sinus pause are the same thing. Sinus arrhythmia and sinus dysrhythmia are the same thing. Different terminology.
Means the exact same thing.
It is confusing, but doctors. Same thing. Sinus arrhythmia, sinus dysrhythmia, same thing.
I'm not gonna lie. So far, it's been the most interesting
Mhm.
thing that we've done the whole class. I'm not gonna lie to you.
I love cardiology, guys.
I'm not gonna lie. It's kind of nice.
I mean, like, kind of hurtful, but okay. That's
Yeah,
fine.
fuck off with your airway, Andrew.
I'm just messing. Yeah,
I
I'm not
wonder
messing.
if they would have said that in Ontario.
Probably. Probably.
You told us. I don't want to do it.
I had a lot of fun. I mean, I had a lot of fun with that class. I don't know about any other classes.
Sick sinus syndrome is a bullshit doctor term for not identifying the underlying cause.
That like restless leg syndrome.
Yeah.
So sinus bradycardia is an underlying cause. Sinus arrest, SA blood. There are real things that we could hammer down to, and instead, a lot of times I say sick sinus.
Oh, so it's similar to.
It's a catch-all.
Fibromyalgia.
Fibromyalgia.
Yep.
Yeah.
It's a catch-all. I don't like it.
What is the seizure one that's like fibromyalgia where they pseudo seizures?
Yeah.
Okay, I've been trying to figure that out.
And yeah.
And those aren't, and that's, but, this is a side note, but that's proven, right?
Yeah, so pseudoseizures doesn't necessarily mean that they're having a fake seizure. So a pseudoseizure can also be kind of like a tick, would be the best way to describe it, like.
Have actually classified pseudo seizures as
It's like a
a mental health problem now.
Yeah. A girl we run that. People not, oh, they're having a pseudo seizure, they can.
Thinking of the other day.
Yeah.
More like.
So, yeah, it's hard, because I would say not all pseudo seizures are fake seizures.
I mean, sometimes they are when they say.
There's definitely plenty of fake pseudo seizures.
It's like the ones where you can just be like, they're faking it and they come out of it and they're like, no, I'm not.
Yeah.
Alright, we have one more thing to cover. No. That's not it. Was that it? Where do we go to?
Oh, this is your PVC.
Okay,
Yeah,
that's what we got.
this is it.
So, well, that hurry. Remember the one where we had premature beat? Let's look at this one. Do we have P waves?
Oh God, I don't know what I did. Hold on.
Oh, Andrew. Oh. He's got it so.
But they're not equal, so it's not correct.
You're gonna click on the wrong thing and, oh, there you go.
You also don't have the proper R.
And now it's pretty.
Everything
Yeah,
on this is fucked up,
the
because it's
R-
like R, yeah, the R distance is
fucked up.
messed up and then the P waves are different.
So but don't worry about if they're different. Is the PRI equal to normal?
No.
So the distance from the beginning to the distance to the end, it should be about the same each time. 1, 2, 3 boxes. 1, 2, 3, in a little bit. 1, 2, 3. 1, 2, roughly 3 when you count that part and that part. So the distance is about the same. So I would say the PRI is equal to normal.
Okay.
So we are in a sinus style rhythm. R to R is equal. No, they're not. But could we come up with an underlying pattern if that circled beat wasn't there? Yes, we could. Okay. So we know we're in some sort of sinus rhythm. What's our underlying rate? 1, 2, 3, 4, 5. 5 times 20 is 100. Let's do it the other way because there's a premature beat in there. 300, 150, 100, 100, 100. Okay. We're roughly at 100. So normal sinus, or maybe sinus tachy's over 100. So what is that beat right there? Premature beat. As a P wave. Premature atrial complex.
Is that you?
It's a PAC.
Hey, that was crazy. You just pulled that out. You do that? Damn.
Oh, I thought you just. So you took away the notes on the sheet, so you on the slide that she gets. It's not a quiz. We're trying to teach. It's fine. No. That's a PAC. Premature atrial complex. If it didn't have a P wave, listen up. If it didn't have a P wave, that P wave didn't exist, and that beat was right there, just like it is. What is it? Not a VC because it's still narrow. PJC. So if we get rid of the P wave, that's a PJC. It's still a narrow beat. We're not really talking about what a narrow beat is yet.
Hold on. How is it a PJC and not a PVC?
The PVC is wide and nasty looking.
Okay.
Premature ventricle complex. So if it comes to the ventricles, it's really wide. So this one's narrow, and it also has a P wave, which means it's originating from the atria. So it's a PAC. Same beat, take away the P wave. That's coming from the junction, the AV junction. So that would be a PJC.
It didn't have
Yeah, so if it didn't have a P wave, if it was this beat right here, wide and nasty, it's PVC.
But because that one is narrow, the QRS is narrow, and because it has a P wave, it is now a PAC. So there's PACs, PJCs, PVCs.
Can we, I know we're not supposed to look at video.
No.
Alright.
What were you gonna say?
I was like, can I just go and like just look to make sure I can differentiate PJ?
No, I don't even care if you can differentiate it this week. There's no homework differentiated this week. I don't want you to differentiate it. I want you to come back next week when we review it, and then I'll give you a packet to start working on. Y'all are gonna hate the packets.
Yeah, you're gonna hate the packets.
Your eyes wanna bleed with the packets. All right, let's do this. Do we have P waves? Let's do our last slide. Good question.
Hold on, let me zoom in.
No.
Do we have P waves? Well, it's hard to tell, right? Let's walk through it. QRST. I don't see a P. QRST. You're like, Nick, I think that could be a P wave. Listen, hear me. The ventricles will always override the atrium. They're bigger. You see them. So when in doubt, is that a T wave or a P wave? T wave in this situation. Okay. Could there be a P wave behind there? I don't know. I'm not God. Could be, but I can't see it, so I don't know. So would we go this way? No. Probably not. Over here somewhere.
Yeah, right.
We have it. But I will tell you, what will you tell me what's the rate? Tacky. Tacky.
Too fast.
Tell me how fast it is.
So.
Do the game.
Well, it's almost 150. I was gonna want to say faster than 150.
This one falls on a beat. 300, 150,
So like 160. No, 155.
165, 170. So it is not sinus tach. It's what we call supra, not super, supra above the ventricles, tachycardia, SVT. Supra, not super. Supra means above. It's coming from above the ventricles. So it could be the AV junction, it could be the SA node, it could be anywhere up there. Above the ventricles, tachycardia.
SVT.
SVT. Greater than 150, narrow complex, tachycardia. This is about where their faces were yesterday when I melted their minds.
So you said above 150 tachycardia. That's all that you need. Just to make sure.
No, this is gonna have a box next week. We're just not to there yet. So there'll be a box
That you fill this in.
that you fill this in. Okay? That's fine. It's all good.
So when in doubt, you're trying to decide if it's a P wave or
T wave.
T wave, thank you. When it's super tacky like this, that's just to go with it's gonna be a T wave.
T waves will always override here.
Okay.
Now on these packets that Andrew's hitting out, that boy. Yeah, we're not doing the whole thing this week because we haven't covered the whole thing. And they're not numbered, which is unfortunate. But you're gonna go to right here. Start on the first page. You don't have to color. We're not coloring. Good gosh, you can color if you want, but you don't have to. Where it says the 1500 method, we're gonna draw a big X through that because we don't believe in that stupid method. Nor does any paramedic ever, because you don't divide by 23 in the field. Can't help Andrew's copy.
I didn't even print this.
Who did this? Copier did this.
Oh.
When we get to this page right, so exit out and stop.
When it says 1500.
Where it says 1500, X that page out. We're not doing that. That is the dumbest thing known to mankind. You can't divide 1500 by 23 in an ambulance.
So this is the example.
This is not 1500 method will not be your test.
It's only writing too.
No, it'll be all right. You won't be outstaffed.
And if you do, good progress in that one.
You would have missed it. You would have missed it anyway because you can't do that now. Okay. So get to here. Get to here and stop. 1500 method, which is on one of the upside down pages of the back page. And when you get to that upside down 1500 page, that's where we're going to stop for the day. The next page looks like this chart. You get to the chart, you've gone too far. That's too far. So we're not doing this chart today. We're stopping on the before that.
So do everything before you.
Everything before the chart. There you go. Everything before the chart. Chart will be next week.
Yeah, don't do the 1500. Do everything before the 1500.
Finally found it. I couldn't find it.
Okay,
Yeah,
so a couple of things. So I want to, I've got to try to meet with, there's way less of you today, to be able to meet with everybody today. But I need to meet with you guys and go over some of your progress reports, because we just finished a couple of the last sections, one of those ones that we signed way back when, a couple of times, got a couple more times, not a big deal. So I want us to stay here till at least 3:30, starting to work on this. That way you guys can help each other out. Use your votes, use your notes, some of these things, okay? Some of these packets we're getting over the next couple of weeks are completion. Just like how some of the other stuff that we've gone over is A&P, right? So I'm not gonna be going through these individually. They're going to be for your help. These are your notes. These are things that you have to hold on to go back. What did he say that one time? What's that first? Is it a P or a T? I can't remember, right? That's what this stuff is for, okay? There will be a packet at the end, and that's like 120 rhythms, something stupid. That one will be for a grade, but it's all the way at the end of cardiology. You're gonna hate it. It's not gonna be fun. Every week, you're gonna get a packet from here on out for the next couple weeks. You're gonna hate it. It's not gonna be fun, but this is the process by which you guys will start to be able to really understand. You're gonna be identifying TKCs, DVCs, and Brady, and all the other stuff, right? So that's what's coming up. So do we have any questions that we can answer in a reasonable amount of time for today?
That's the math. Those packets, yes, you can cheat, you can do whatever you want. You will never learn this if you don't do the packets. Every rhythm ever is identifiable. There's an answer. You will hear medics be like, I don't know, that's not. No, the answer might be, I need a better 12. Sometimes I'll give you an answer of, I need a better 12. That's too much artifacts. That could be the answer. But absent of that, absent of artifacts, there is always a right answer. And most 12 leads, if I take them down the hallway to your agency, my agency, I can get 12 different answers. That's messed up. Because there's a clinically right answer.
Some of this is gonna feel annoying. You're gonna understand why when we talk about that, we talk about it as rhythm interpretation. You can get a perfect 12 lead that can show everything, and I can show it to 2 cardiologists, and they'll probably argue about what the access deviation. And that's just, and we don't even, I don't know. Okay, somebody else probably maybe knows, but I don't.
So the answer might be, we need more information. The answer may be, that's not a very good looking 12 lead. But I can get you out of this algorithm, I can get you somewhere. I promise. If we all apply the algorithm, this is why I don't want to talk to other people, we can get somewhere. There is an answer. But the fact that you can get 10 different ones, that bothers me.
And part of this whole thing is, and I don't know if Nick already said it yet, but some of this is going to come down to, you have to treat your patient and not the monitor. If your patient is sitting at 55 beats a minute, 50 beats a minute, okay? But they're sitting there chilling, we don't need to work. Their blood pressure is good, SpO2, all that sort of stuff is good. We don't need to worry about the fact that they're in a Brady rhythm. Maybe they're a runner and they run 15 miles a day like idiots. Maybe that's what they do, right? Okay. So we need to treat your patient and not the monitor. If your patient looks like shit and your monitor says, I don't know what that is, maybe we start to dig into those things a little bit. But if your monitor is screaming at you, but your patient's sitting there, ANO ×4, blood pressure's good, all that sort of stuff, we need to check something, and it's probably not the patient, right? We need to check where our lead placement is, ask if they've got some histories, those sorts of things, right? So that's one thing that we've got to make sure that we drive home when it comes to it, okay? We don't treat just the rhythm. Okay? All right. Any questions at all about today so far?
I think today's fun, next week gets better.
It really does. Again, as you start to build on things.
I love it. It's fun. Like you guys, and you're gonna feel like medics, right? IVs felt like medics a little bit. Airway felt like medics a little bit. You're about ready to really start feeling like medics.
Next week at the end of class, as long as my clinical student's done, for those of you I've already talked to, like you can sign up for your clinicals. So like we're at that point after next week, we feel like you have a general kind of base knowledge about enough stuff to go pretend to do some things in the ER.
I'm a good pretender.
Well, before they go to the ER.
Okay.
Next week.
So next week,
remind me.
well, next week, thankfully, you're gonna be here.
I know. Just remind me to do the ER.
Okay.
Because there's.
All right. Good. Okay.
For the sympathetic and parasympathetic for the verses, do you want us to like make like that chart that you made, or just explain like cholinergic versus
Whatever works best for you. This is a completion grade. Guys, there's a lot of things we do in this program. Like I could be a Nazi, Andrew could be a Nazi, we can make sure everything's perfect. Or we could just say, do it so that you know it. Like I don't know. Some of it's just like
If you just decide not to do this, then you're gonna
You're
have some
good.
questions about this in a cardiology platinum test and then on national registry, and that was kind of on you.
right. We want you to succeed. All right, I'm gonna leave.
Okay.
Here. Leave here for my house. Trying to catch up on my guys.
So this may just be a reference page, but this
Oh, okay.
for you to be able to kind of look at, but maybe then start talking about what answering some of these questions, or maybe this one's probably just talking about doing a definition. What is your heat wave? Where is it? Or like, what are you looking for? What's normal,
This is the worst.
Okay. All right, Bridget, you want to, just since you're right here first. I will come check the room before we go, but we do have an EMT class in here tonight, so if we can just kind of make sure the chairs and stuff are pushed in. When you guys going, like I said, there's not very many of you, so I should be able to meet all of you.
Elevation.
And so.
I'm trying to figure out how I should write these stars so the simple comparison.
Honestly, I'm not.
It's like the way he wrote it. I don't know, I don't know if I could like look back at it, like, I get. And it brought back, like. For the. Like I know the sympathetic, you're gonna use the,
Sympathetic versus parasympathetic affects the heart.
Yeah, but they both.
And then, yeah, not. We should control the chart.
That's what I'm doing. I'm thinking maybe just write the chart and say what each one does. One of the next, but make it look like his. You know what? This is gonna be cheating.
I don't want to be cheating. I'm just.
Yeah, 6 seconds on it. Slowing down and make you think about it as you read it.
I don't want this shit. Who is? Or what? So I haven't logged shit. This is my bad. I get so confused.